do the kind of job that I do, we deal a lot with politicians. 9 o'clock, it's 11 o'clock. That's like standard. So when we start on time, we're like, what is this? Ladies and gentlemen, welcome to the 2022 GEMS Symposium. My name is Clement Manyatela. I am a talk show host. I work for Radio 702. I host the Clement Manyatela Show. In fact, I start my show at this time. I'm probably saying Dumelang to my listeners, and I'm about to take their calls and fight with them. But I'm very honored this morning to be the facilitator of this symposium. And I also work on Newsroom Africa on Channel 405, and I'm really, really honored to be part of this symposium. So thank you so much for joining. This is the first hybrid GEMS symposium, which is exciting, right? Because we are social beings. So when we go back to some form of normality and we do these in-person events, it helps a great deal because we can't really survive in isolation as social beings. So it's always great to have this in-person events. And we're so glad that although we would have loved to have all of the people on site, we're excited that all of you are actually able to join us virtually. I'm told that we're looking at about 700 or so participants, which is wonderful. We're not only streaming this on our Zoom platform, we're streaming it on our Facebook page as well. And in fact, you can hashtag GEMS 2022 Symposium. That's where you can find us. It's the hashtag. And on Facebook, GEMS One Gem of a Scheme. It's the same on Instagram. You can find us on LinkedIn as well. And I have no doubt that this is actually going to be an insightful and beneficial session. The theme for this year is the value co-creation for a patient-centric health system. And I don't need to tell you how important it is for that patient-centric approach, whether you are a medical aid, whether you are a business, any institution for that matter. If you are not putting your patient or your client at the core, that business is not going to survive. And we're living now in an era where as patients, we are evolving, right? We demand better healthcare. We are more informed. We know what we want. So it helps for medical aid to evolve with patients in this new era of a new age patients. And I think my guests this morning are going to be elaborating more on that, the speakers that we have through their presentations. Before we begin, I would like to alert our online viewers that the Q&A section is going to be open. So towards the end of the symposium, we're going to take some questions. Don't go to the chat section. Please ask your questions on the Q&A section. And towards the end of the symposium, we're going to take your questions. And please, when you ask the questions, can you please direct the name, just write the name of the person you're directing that question to. And we're going to try and allocate enough time for you to have your questions answered. So with that said, can I please ask that we stand so that we can say Thank you very much. We still have some people still learning the lyrics of the national anthem. I was watching all of you when it goes, and you blow, yeah. Fascinating stuff. I just want to mention that we're expecting to be hit by load shedding at around 10 o'clock. But don't worry, the generator is going to kick in almost immediately. So if you are participating virtually, please note, if you are kicked out, we're gonna ask you to please log in. It's gonna be very easy for you to log in because the generator is going to pick up almost immediately. All right, with that said, ladies and gentlemen, please let's welcome on stage Dr. Millicent Tlhatswayo, who is the chairperson of the GEMS Board of Trustees, who will welcome us. And she's joining us virtually.
Thank you so much, Mr. Manyatela. I wonder if you can hear me. Can you hear me?
Dr. Tlhatswayo, I think you are muted.
I'm muted at the moment.
All right, we're going to try.
Can you hear me now? I'm still muted. Unmuted. Mr. Manyatela, can you hear me now? Somebody said they can hear me. Okay, thank you so much, Mr. Manyatela. Deputy Minister of Public Service and Administration, Dr. Chane Pilane Majake, Director General of Administration, Ms. Yoliso Makasi, General Secretary at the PSCBC, Mr. Friki de Brain, GEMS Board of Trustees, GEMS executives, our esteemed panel of experts and healthcare practitioners, distinguished guests, members of the media, ladies and gentlemen, good morning. Program Director, please allow me to take this opportunity to welcome every one of you in the 2022 GEMS Symposium, which is in value co-creation for a patient-centric health system. The focus will be on the sector embracing the next generation health system that is patient-centric and co-creates value with collaboration with all stakeholders. My name is Dr. Sebaiteng Millicent Tlhatswayo. I'm the chairperson of the Government Employee Medical Scheme. And I wish to thank you for making time to be with us today. Your presence and participation in this important event in our nation's health calendar is indicative of the importance you place on our healthcare system and coverage at large. We are delighted that you have chosen to participate in the 2022 GEMS Symposium, where we will discuss and advocate for the development of South Africa's next generation patient-centric health system. GEMS has recognized the importance of patients' participation, healthcare decision-making, and incorporating patient perspectives into the spectrum of care. However, there is still much to learn about patient engagement and patient-centered approaches. Putting the patient first involves open and sustained engagement of the patient to achieve the best outcome and experience for them. And we are pleased to have people in the room who to share this vision with us at GEMS. As a participant in this symposium, you will help shift the agenda towards creating a patient-centered system where we co-create value for patients. Today's agenda will cover interesting topics presented by aspiring, inquisitive, and intelligent minds who are deeply committed to quality healthcare continuity. We have been deliberate in highlighting the critical areas for discussion during the symposium, because together with you, we hope to arrive at solutions and strategies that are relevant to our current times. In addition, by working collaboratively, we hope to gain insights and perspectives from all our healthcare partners, key stakeholders, and policymakers. Today's discussion will explore the following: a roadmap to a patient-centric health system, ecosystem value co-creation, why member education on NHI is important, advancing women's health, reducing out-of-pocket payments, optimizing beneficiary choices, and patient-reported performance outcomes. These key discussion points are designed to help us be better prepared to face future challenges and provide specific outcomes and value to meet our members' financial and healthcare needs. A critical component of patient centricity is identifying clear objectives to incorporate the patient perspective into different life cycle processes and operationalizing them. In addition, we must track progress towards key performance indicators and return on investment. It is more important than ever to leverage digital and data analytics opportunities to engage patients and collect data on patient outcomes and unmet needs. And as we are doing today, continue to build deeper partnerships within the industry with advocacy groups, clinicians, and health plans, and leverage lessons learned from other more patient-centric sectors. Now, ladies and gentlemen, as I reach the end of my opening address, and I have been given the pleasure to introduce our next speaker, she probably needs no introduction. However, joining us today, we have the Deputy Minister of Public Service and Administration, Dr. Chana Pilane-Majake. The Deputy Minister has been a member of Parliament of Republic of South Africa since the 4th administration and has served as a member of multiple portfolios, such as the Justice and Constitutional Development Portfolio Committee, the Ad Hoc Committee for the Code of Judicial Conduct for Judges, the Public Enterprise Portfolio Committee. She was a member and a whip for the Justice and Correctional Services Portfolio Committee and the whip for the Peace and Stability Cluster. Dr. Chana Pilane-Majake was reappointed as the Deputy Minister for the Public Service and Administration on the 5th of August 2021, and she's currently in the 6th administration of Parliament. She serves as a programming whip of Parliament, a member of the Ethics Committee, and the Multiple Party Women's Caucus Committee in Parliament. She holds a doctoral degree from the University of South Africa, a master's degree in social science from the then University of Natal, now part of the University of Zululand, an honors and a bachelor's degree from the then University of the North, now University of Limpopo, and a diploma in development studies from Stanford University in the USA. As the Deputy Minister for the Public Service and Administration, Dr. Pilane-Majake has been working tirelessly towards the improvement of a people-first public service that promotes the principle of Batho-Pele. As I take my seat to bring up the Deputy Minister, ladies and gentlemen, I ask that you all participate openly, engage, and contribute to expertise today, because doing so will see us co-creating the patient-centric solution of healthcare needed in South Africa. I'm looking forward to insights I am confident that all of us will emerge from today's discussions with a richer comprehension and appreciation of the value of creating a member-centric health system. It sounds like a tall order, but we will do it together. Deputy Minister, over to you, and thank you. Over to you, Mr.
Thank you, Dr. Hlajayo. Thank you for the introduction. Let me also just acknowledge the presence of the Director General for the Department of Public Service and Administration, Yolisa Makasi, the GEMS Principal Officer, Dr. Stanley Molwabi, the Public Service Coordinating Bargaining Council General Secretary, Friki de Brain, the health providers present here today with us, members of the media, GEMS members, and distinguished guests. Program Director, let me start by first applauding GEMS leadership and partners for hosting the annual GEMS Symposium 2022. This year's symposium, with the theme patient-centric care, provides an ideal opportunity to discuss the importance of providing patients with the best possible healthcare experience. Patient-centric approach to care involves patient and family-centered care that encourages collaboration and shared decision-making between the patient, his or her family, and healthcare provider or providers. The Institute of Medicine defines patient-centered care as providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. This approach, it is said, requires a true partnership between the individual, their families, and their healthcare providers. This is an approach that resonates with Batupili, people first, public service principles. There can never be any meaningful enhancement of healthcare without the active involvement of various stakeholders, including the patient and his or her family. It is therefore encouraging also to see the respective stakeholders, including labor, represented in the symposium today. This is precisely how we should collectively be moving in developing patient-centric model that sets standards on interactions between patients and healthcare providers. The symposium should therefore ensure that the collaboration by all stakeholders finds expression in how healthcare services are administered and experienced by patients. The symposium, I have been advised, seeks to develop innovative mechanisms and standards that healthcare sector stakeholders in collaboration with GEMS can use as a blueprint for best practice in rendering services to patients. Setting standards in this regard will certainly elevate healthcare performance you are responsible for. The core objective of the symposium is to bring together partners who are patients, key industry role players, and policymakers in the healthcare sector in a bid to improve healthcare service delivery for public servants. I can therefore safely say, as we are gathered here today, there is urgent need for this kind of healthcare in our approach to enable patient-centric healthcare experience. COVID-19 pandemic experience reminded us about the need to fast-track innovative, easy to access, and safe digital healthcare systems. Also important to patients is affordability of healthcare. This cannot be achieved without insight that comes with understanding patient-centered economics of the healthcare sector. Program Director, today's program will also focus on better health for inclusive women's health in line with the NDP and Sustainable Development Goals. With October being the Breast Cancer Month, I am hopeful that the symposium will come up with patient-centric approach of dealing with this ailment that annually takes many lives of women. That is, mothers who leave children still yearning for their love and care. The patient-centric model that the symposium is pursuing will contribute to reduction of inequities in healthcare. Patient-centric socio-economic approach to benefits is but one of the ways in which such challenges can be dealt with. Chairperson of GEMS, I have been reliably informed that there are existing digital health initiatives that have proven effective in the management of patient data, PEPOPIA, Protection of Private Information Act requirements. However, we still need to ensure that patient-centric and user-friendly interface becomes standard as a vital aspect of a digitized healthcare service to improve patient experience. Most role players in the healthcare sector know that there is no doubt that patient centricity is central to the future of healthcare services. We all need to appreciate that in any change of a way of life, there will be momentary disruptions, especially where new innovation is to be applied. The same applies to the in-health sector in our bid to realize the ideal future of patient satisfaction and strong health system outcomes and experience. Despite the remaining gaps in health sector to achieve the aspired patient-centric model, there is still scope for improvement using strategies to be developed from today's seminar or symposium. Improving patient centricity also requires collaboration among sector stakeholders that include patient advocacy groups and healthcare practitioners associations, as well as labor organizations. However, there is a need for the industry to advance meaningful partnerships beyond this. The first step towards increasing efficiency, improving quality of service, and patient experience of healthcare is to put and always put patients first. I therefore invite all participants in the symposium to take advantage of today's engagement, to come up with innovative strategies to strengthen healthcare as provided by GEMS, using the suggested patient-centric model for quality, affordable, and equitable healthcare for South Africans, including public servants, as advocated by the National Health Insurance. I wish you success in your discussions and look forward to seeing your work revolutionizing the approach to healthcare for public servants and their families, inform public service policy formulation, and most of all, improve patient experience of our healthcare services. I thank you, Program Director.
Thank you very much, Deputy Minister. Thank you to Dr. Hlatshwayo as well. And the Deputy Minister talks about the kind of healthcare that is urgent. This approach is urgent, and it's coming at the time when you realize that you're setting the standards that's going to elevate the healthcare performance that GEMS is responsible for. And Dr. Hlatshwayo did say that it sounds like a tall order, but it's something that's possible. And I'm glad that we've got all the different stakeholders here, not just GEMS, but the patients, we've got the partners, we've got policymakers who are going to help in implementing and having discussions around this approach. Remember, if you want to tweet, you want to share your thoughts, you can just hashtag GEMS Symposium 2022. And then remember, as you hear the presentations going on, just prepare your questions. And towards the end, we will bring you in. Just put your questions on the Q&A section, and you will have to indicate the name of the person you're directing the question to. So we're talking a lot about this patient-centric approach. Let's now welcome Dr. Stanley Mulwabi, who is the Principal Officer at GEMS, who will talk more about this approach.
Everybody, and as a program director for today, thank you very much for stewarding this symposium, which is always something we look forward to every year. Clement, I was just thinking that at least you're going to be talking only today. You won't be dancing. I have been introduced as the principal officer of GEMS, which I am, but I also come from a family, and I'm a nephew to somebody. So I just want to share a brief story that happened actually in the past 2 weeks relating to patient-centric healthcare. So one of my family members, who is a retired public service employee, phoned me and said to me, and then, the family members, they refer to you as that child that they brought up. So she says to me, Bujosi, which is my first name, why my account? Why haven't you paid my account? So she had just undergone a procedure, and she's a member of GEMS, and we haven't paid something. Something was rejected. So family members, they always phone me, and then we usually follow the same process we follow with everybody else. And then I said, well, I will investigate why we did not pay. Then my team checked out, and it comes out that the rejected treatment was one of those experimental treatments. And then I went back to explain to her. And then her reaction was that, okay, why didn't the doctor tell me that they are going to use medicine that is not yet standard treatment? And I said, well, it's one of the problems we deal with. And it is, and then she then went on to say, well, even doctors, they don't care about us anymore. They do all these things, they don't explain to us. So that conversation just, had resonance with what we are talking about today. So just to put it into context, I thought I should take one of the many definitions of what patient centricity is. And I'm taking this definition from Neil O'Neill, who says patient-centered care is a practice of caring for patients and their families in ways that are meaningful and very valuable to the individual patient, and includes listening, informing, and involving patients in care. The framework that has the WHO has also come up with talks to three areas. It's basically talking about people-centeredness around the individuals, which are patients, families, and ensuring that they are able to participate when responding to their healthcare needs in a human manner. And then the second thing, it talks to stakeholders, and it talks about involvement of everybody, whether it be healthcare practitioners, healthcare organization, whether it's private and public sector organizations that are involved in healthcare, they need to be involved. The third part talks to issues around what legislation in the world seeks to achieve in terms of human rights, the right to dignity, non-discrimination. So all of these cornerstones of a patient-centered approach, they actually touch various elements of involving different parties in health. So in trying to achieve this, what is it that we are trying to achieve at GEMS? What have we done at GEMS? We talk about walking the talk. Walking the talk, as you know, it's defined as doing exactly what you say. You say it in words, but you do it in reality. It's similar to, I don't know if it's a theme where Clement works at 702 Radio. So some of the things that we are doing is we have increased, we have increased patient engagements through multiple channels. And at the beginning, the program director spoke about how we can be hashtagged. We have media platforms. We have member apps that our members can interact with. We have working centers in all the provinces. And then we also have client license officers in all the provinces, and provider license officers to also talk to the healthcare providers. This is where we get a lot of interaction with our members who happen to be the patients who seek help from the healthcare providers. And our provider license officers interact with the doctors for the doctors to understand what is it as healthcare funders that we are responsible for. And this has resulted in increased member satisfaction. Our member satisfactions have averaged over 90% since we have started gaining from all these various initiatives of interacting with members and ensuring that we educate our members as best as possible. We also had to respond to the COVID-19 pandemic in 2020. And overall, our response has been that we have been able to be there for our members when they needed us most, and paid quite a lot of claims relating to COVID over the past 2 years. It's now in 3 years. And in terms of vaccination, there was a lot of messaging that went out there to the extent that within the GEMS population, we achieved more than 70% vaccination rate. And then one of the things, apart from just the media platforms, the social media platforms that I spoke to earlier, we also seek to have our members have increased access to information so that we deal with information asymmetry through our GEMS days, which are generally, we are now, they are held virtually, but there are also Lekotas where we interact with our members in the various regions of the country to ensure that we explain to them what GEMS benefits are and what healthcare funding, how you should use your medical aid. And then we also engage with various stakeholders in terms of our constant engagement with the various stakeholders. And those various stakeholders are through the very same Lekotas and the like that I've spoken to, but we also have constant interaction with the healthcare providers. We have a healthcare provider strategy that engages with the doctors We also have where we have big occasions which are sponsored by GEMS, where we interact with the various healthcare providers in their initiatives. And then in terms of how we are remodeling the products of GEMS, we have had immense success with our two products called the Tanzanite One and the Emerald Value options, which are aligned to the universal healthcare principles. And the bias there is towards primary healthcare. At primary healthcare, that's where a lot of conversations can take place, where you talk with your family physician or the general practitioner, you know, your day-to-day work. That's where we expect a lot of conversations to happen. By the time you need secondary and tertiary care, things become a bit technical. They are driven by technology because now we are dealing with advanced disease. So our bias towards ensuring that in our care coordination, there's a lot, members must always start with the family physician. That bias will assist in patient-centric care, in that a lot of conversation happen in the family medicine space. And we have, you know, Professor Morgan Chetty here, who is a family physician. And I'm sure he'll be talking to this as well, how much it is important. This is just a graphic infograph of also demonstrating some of the things. When you say we are working the talk at GEMS, we do a lot of things to improve our platforms, the platforms that enable interaction with the scheme. So there have been improvements made on our GEMS web portal in the past year, and then we continue to improve the mobile app and try and encourage more take on because not everybody is technologically savvy. So, but these are some of we are focused also on marketing activities to drive the adoption of our members facing digital platform. We are also on Facebook, you saw earlier on. And then we also have various partnerships with the media, like the GEMS on the channel. We have Health Matters on ENCA as one of those. And then the Symposium is also a platform for us to interact. So as I conclude, there are some principles that have been suggested, and these have been suggested by the same Neil O'Neill, whose definition I used at the beginning of the presentation. He defines 8 principles that really should be part of patient-centric care, which is respect for the patient's preferences, coordination and integration of care. I spoke about care coordination in our EVO and Tanzanite One. Information and education, there's a lot of emphasis of information and education sharing with patients, which we do through our various inter-engagements like the Lakotas and the GEMS days. Ensuring that there's understanding that when you are a patient, you don't just want the doctor to focus on the diagnosis and then solve the diagnosis. There are issues of physical comfort, emotional support that are needed. And you are not the only one who's suffering. The family is also suffering. So the involvement of the family and ensuring that there's continuity of care. When you move from primary to tertiary, there must be continuity of care. But also very important is that we must promote access to care. And one of the things we really focused on at GEMS is promoting access to care. So at the end of it all, and I'm sure we are going to talk about this throughout the day, patient-centered care should be the one that asks, how can I make your experience better here? As the ideal approach than the one that says, you know, that patient-doctor relationship where there's imbalance of power, which would say, this is how I'm going to treat you because I'm the expert. You just receive there and then don't get it. So this is really what I'm hoping by the end of the day, the message that we will have achieved. Thank you very much.
Thank you very much, Dr. Molwabi. And yes, walk the talk is our tagline. So I will be sending an invoice to GEMS. No, but seriously, I mean, at 702, when we came up with this tagline was, we want to encourage people to walk the talk, because we say a lot of things, what we want to do, and we often don't follow it up with actions. So hence we say we walk the talk. I spoke to my mom last night and she wanted to know what I'm doing. And I don't know why, but our parents, doesn't matter how old you are, they think you owe them an explanation. Why are you not at work today? I've got stuff to do. What stuff? So I told my mom I'm coming, I'm facilitating the GEMS. She was excited because I'm a baby myself. I was raised by GEMS. So she said to me, okay, who's going to be there? I was like, all the important people. And then she said, okay, remember when I called you stressed about that out-of-pocket payment? Like, yeah, ask them about it. So I told her, no, actually, there's someone who's going to be talking about how that out-of-pocket payments can be reduced. And this is something I know for sure frustrated her a lot. She was calling and saying, I'm paying every month. Why must I pay out of my own pocket? So I'm so glad that that's another subject matter that's going to be addressed this morning. I would like us to welcome Mapato Ramokgopa now, who's the divisional manager for market conduct at the Competition Commission, who will be talking to us about this next generation member engagement tools. Let's give it over.
Good morning, everyone, and thank you, Clement, and thank you to GEMS for the opportunity. It's a bit intimidating to speak after everyone who has a title of doctor. Sorry, Clement, to break the chain, but I'm working on that PhD. Hopefully, next time I'll be speaking as Dr. Ramokgopa. I'm going to be talking about information asymmetries that impact access to healthcare, but in particular, information asymmetries that characterize the South African healthcare system and which disempower, in particular, the consumer. We all know that the South African healthcare system is characterized by high costs and increasing expenditure. There is excessive utilization without any corresponding measure of improved health outcomes. Some of the things that we picked up when we did the health market inquiry by the Competition Commission was that there is an imbalance of power between various stakeholders in the industry. So we found that there is more market power on the part where there is the price or cost insensitivity from myself as a consumer, because I know that the scheme will pay. So there is that sense of insensitivity sensitivity when coming to costs. And Dr. Sten reflected on this on the coordinated care, but I think one thing that we found was that there is a lack of defined health pathway. So this wields information advantage over the funders and patients, where you find that care is being accessed at inappropriate levels, largely at secondary and tertiary levels, totally ignoring the primary care level. Again, this a lack of defined health pathway impacts cost sensitivity. There is a problem also of product complexity. We have over 73 medical schemes. There's about 170 incomparable benefit options. You've got gap cover, you've got hospital insurance. Those products just totally disempower the consumer. Wasn't I horrified when my dad called me to say that he canceled his medical scheme, medical aid, and he's going for a hospital plan, and was advised by an agent of a medical scheme to do so. And it affects a lot of people. And fortunately, maybe with my experience in the sector, I was able to stop that move to cancel his medical scheme. He's a 70-year-old man. And I just told him, I don't know who gave you that advice at your age to do this. These are some of the challenges of a lack of information. But there are also regulatory gaps that contribute to the information failures. There's a lack of a proper price determination framework. As a result, you see an oversubscription of a fee-for-service and lack of proper risk-sharing reinvestment models. And it's something that the HMI reflected in detail on. And I'll make an example of the case that we did last year, the commission, the COVID-19 PCR test, right? No one can tell us why that price was at $850. There was absolutely no information that justified that price. And it took a reactive approach by the commission to try and drop that price to what we achieved ultimately. Had there been a proper price determination framework, that price probably would not be there, because that system would force all the information to come out so that the proper pricing can be determined. And that lack of price certainty also leads to significant out-of-pocket payments. The review of the PMBs is long overdue. As a member, I need to know what is a PMB, what is covered when you talk about PMBs. Is it covered in risk or MSA? And what is that price that has to be paid in full? And the fact that you say that the price must be paid in full, does it really have to be paid in full, or can I negotiate that price down for it not to be paid in full? And I'm as much as I'm a professional, I deal with a lot of family members who come to me and say, I went to the doctor, this was not paid up. And then when I try to follow up, it's a PMB, it must be paid in full. And if Leila was not such a committed public servant, I could start a consultancy firm that just files for people's PMBs to be covered. So I think we need to, think about the process of reviewing the PMBs, but also educating our members what a PMB is and how it should be covered. There's also lack of a data sharing framework and outcomes monitoring. One of the key things that the HMI was able to achieve was getting data from various stakeholders and combining it and coming up with a very detailed data set that has claims data, that has clinical information, and we were able to use that information to make certain recommendations and make certain analysis. That is lacking in the sector, and it should be something that the sector has, where you can have this data set that can be used for various purposes. You could use it for for monitoring disease burden, picking up trends, for outcomes monitoring. You could use it for health technology assessments and things like that, but also to empower patient advocacy groups. I mean, if you have this data set, you can be able to use the data set to say, we're picking up these trends in utilization, mortality in these areas, and these patient advocacy groups are able to then engage with the schemes, but also with the constituencies in an informed position. I think I've touched on a bit on this, just the lack of economic value and health technology assessment. The treatment that is sometimes provided, it's really not based on proper economic evaluations. It's not based on thinking about the resource framework and resource constraints that face us. I think all of these issues just generally disempower patients. So what can be done? Generally, when you look at economic literature, market failures are corrected through government intervention, where we can pass policies or regulation that bridge the gaps. So in that regard, I think there is space to start thinking about policies that can encourage a price certainty, where we can develop a tariff setting mechanism that would also include the problem of clinical codes that have been updated for some time now. There's individual initiatives that are taking place, but I think there needs to be a much more coordinated approach to coming up with a tariff setting mechanism, particularly on the provider side. We need to move away from fee-for-service. It's perverse. It encourages overutilization, and we need to start working to implement risk-sharing models, but also effective use of DSPs. I've mentioned the issue of a PMB review is critical. We need to know what these PMBs are and what is covered for these PMBs. Benefit comparability, a key recommendation that the HMI made to the industry was the introduction of a comprehensive standardized basic benefit option. So you have this one comprehensive basic option that everybody can have access to, and then if you want additional cover, you can then upgrade. And this process should be linked to the PMB process. And the example that we always provide here is that when we did the banking inquiry, at the time, we were able to recommend the introduction of the Mzansi account. I think it was the Mzansi account at the time, and that Mzansi account did well to at least expand access to banking services. I think something similar can be achieved in the sector. We need to start defining the healthcare pathway. We need to empower members to follow the appropriate channels. I shouldn't be going directly to a pediatrician for a cough. HTAs, health technology assessments, economic value assessments. We need evidence-based interventions so that we are able to use our resources efficiently. I've mentioned the issue of a health data sharing system. This system will empower all the stakeholders. It will empower the funders. It will empower the practitioners. It will empower even patients and patient advocacy group, but also just monitoring of outcomes and also boost health research. As I mentioned, I'm doing my PhD, but just getting data to do my studies that probably could benefit the sector. It's not there. It's not there. And I can tell you that when we did our data set at the HMI, we got many requests from academics, industry players to access the data set to facilitate research. But because that information was subjected to confidentiality claims, it just could not be made public, but it was just information that was so useful to the sector. I think some framework can be developed to develop that data sharing framework. Outcomes monitoring, we need to know the health outcomes, and it shouldn't be individual initiatives that come out. I know I've worked with the HQA, for instance, they're coming up with a system of outcomes monitoring. There are other processes that are taking place, but we need an integrated system of outcomes monitoring. It empowers all the role players. It allows the providers to peer review and benchmark. it allows the funders to assess whether there's value for money for what they're paying. And also, as I said, it just allows patients to be empowered based on outcomes. And all of these issues really, if you go back to the health market inquiry report, these have been proposed and recommended based on the inputs of the industry. But to date, these recommendations haven't been implemented. And unfortunately, lack of action on some of these things means that these failures in the market will persist. And it's important to state that the key challenge when we engage with stakeholders why these issues have not been addressed or implemented is that we need legislative reforms, we need government interaction, correct? However, I do believe that some issues don't really need legislative reforms, and the current acts or legislation that exists that we could use to implement some of these recommendations. So we could use the Competition Act to see how we can facilitate some change in the sector. We can use the Medical Schemes Act, and the Chief Justice who we used to work with used to always remind us that the National Health Act is so broad that some of these changes we can still fit in within the National Health Act. So I'm encouraging the sector that let's see how we can use these pieces of legislation to try and facilitate reforms. I think it's important as we transition towards the NHI to start working on things that would just make the transition easy. I don't foresee an NHI that can work without some stability in terms of, price determination, in terms of, like clinical codes, for instance. It's something that needs to be addressed. We need these changes for us to be able to efficiently transition to the NHI. Let me end it there. Thank you very much.
Thank you very much. I think we should clap again for future Dr. Ramaphosa. Thank you for that. And you, so many educating members about benefits, data sharing framework. So there's quite a lot to do, not only from a policy and legislation point of view, but just from by GEMS as well. Now for the big question of the day, a big question that many patients, and it's the big elephant in the room, so to speak. And it's about reducing that out-of-pocket payments. And Barry Childs has the tough task of addressing this issue. Barry is a joint CEO of Inside Actuaries and Consultants. So please let's clap Barry as he comes up.
Thank you very much. I must say I didn't anticipate quite such a lot of hot potato on the topic when I was asked to speak on it, but I look forward to sharing some insights in our thinking in this area. Thank you so much to GEMS, Stan, executives, board members for the opportunity to speak to you today. So just want to briefly set the scene to make sure that we're all talking about the same thing. There's sometimes some confusion about what we're talking about in out-of-pocket payments. Really, what we're talking about is at the point of care, at the point of getting the healthcare service, if you have to take money out of your pocket to pay over and above what your insurer is paying or your medical scheme or the services provided by the public sector, then that is an out-of-pocket payment. It's very difficult to measure at a system level, but we have reasonably good data on that at the medical scheme level because we see claims that are short paid or not paid for whatever reason. Generally speaking, out-of-pocket payments are regarded as the worst form of healthcare funding. There's no risk pooling. They tend to affect lower income households worse. They tend to affect those in ill health worse, and they're regarded as the most regressive form of healthcare funding. So how does South Africa look globally here? And we've always, because of the structure of our system, we actually look quite good, although it hides a darker side to the metrics. Generally, what you want in a healthcare system is low out-of-pocket payment, which would indicate that there's good risk pooling. And South Africa has very low out-of-pocket payment compared to other countries, below 10% by the latest measures, which by international standards is very good. If you look on the right-hand graph, I've done a little circle around South Africa. For our GDP, we have very low out-of-pocket payment compared to other countries in that GDP range. And if you look at the map, you can also, it's very clear that on that measure in particular, we perform quite well. However, low out-of-pocket payments are a good thing, but they also signal low disposable incomes and financial barriers as access to care. In other words, if people just don't have the means even to make those payments, then they don't access care. So the flip side of the coin of having low out-of-pocket payments is that it is an indication that we are inhibiting access because of the cost of care. I mean, in South Africa, we live in a country where 50% of the population are living in households earning 5,000 Rand a month or less. So the disposable income for healthcare services over and above, what it costs just to survive is very low. And so that partially explains the figures that we see here. In the literature, in the health economic literature, there's a lot of talk about out-of-pocket payments and how to reduce out-of-pocket payments because they're not ideal as a form of healthcare payment, and that's counterposed by can out-of-pocket payments be used as a tool for some of the difficulties in health system efficiency and access? So, are they a tool or do they torment the system? On the torment side, because of the structure of health systems, whether they be public or private, there needs to be some kind of rationing, either through clinical protocols or management of access, constraining supply, formularies, managed care protocols, etc. The list goes on. Where there are benefit limits, such as in the case of medical schemes for non-PMBs, invariably people are going to hit those limits, and when they hit those limits, they would be required to pay co-payments, or there may be exclusions or various other things that can cause hardship for patients that need that care. In the case again of South Africa, because we don't have an embedded mandatory income cross subsidy policy with the medical schemes, this means that if you have lower income, you would generally have to buy lower cover and have lower access to benefits. That's got nothing to do with your health. You may be very ill, but because you have low income, it means that you'll have lower access to benefit. And then if you need to access more expensive benefits, that would result in an out-of-pocket payment. So a regressive system, which isn't ideal. Fortunately, in the case of GEMS, there are significant income cross subsidies, as there are for many other restricted schemes, and that solves this problem. So you typically see that in our environment where restricted schemes have fewer options and much less of that sort of choice problem that the previous speaker mentioned, because there are income cross subsidies, so there can be a consolidated list of benefits. But again, out-of-pocket payments can affect the poor and the vulnerable the worst, which is why they're not ideal at all. On the positive side, as used as a management mechanism, things like co-payments can be used to incentivize the right behavior, not only for patients, but also for providers and doctors, and mitigate the kind of third-party payer risks. There's no skin in the game in this insatiable drive for healthcare that I'm paying this contribution and therefore I should be entitled to have all the tests and go to all the providers that I like right away. And so co-payments can be a disciplining mechanism in the system to say, well, if you want that, if you want to use the most expensive medicine, then there should be a co-payment. Of course, what's critical there is member education and cost-effective alternatives that don't attract a co-payment. But all of those things need to work together to make sure that patients and providers make the right choices. And then there are other elements that can also result in co-payments and that insurers need to protect themselves from, particularly anti-selection. So sometimes there'll be exclusions for things that are not that are more elective. Typical exclusions like plastic surgery and these kind of things, where we would, if they were allowed in the medical scheme environment, people would join and have their treatment and then leave, and that would destabilize the funding pool in medical schemes. So there is a balance between these two, and it is a fine line to walk. There is only so much money. There are no free lunches here. Medical schemes operate in a not-for-profit environment, and so they would love to pay more benefit, but that unavoidably leads to higher contributions. And so that's the dynamic that medical schemes have to manage all of the time. It's not only a medical scheme problem in the South African context. So we know that within our overall population, we have about 15% coverage within the medical scheme population. And I'll talk a little bit more about I'll focus some more about out-of-pocket payment management within the medical scheme population. But we know that another 13-14% use private providers as their first port of call, according to the General Household Survey. And an even larger proportion of the population, 46%, live in a household where private care was purchased in the last year. So this is now a significant part of the population that are not part of medical schemes, that are still making use of private providers and are paying out of pocket for that. In the short and medium term, the solution for that is a product solution, and that's why there's such a lot of emphasis on the so-called low-cost benefit options, which we've been debating since 2006, another reform that really hasn't gone anywhere with any pace, but we're hoping that we'll get there soon. But of course, in the longer term, that's the NHI that is aiming to solve these kind of problems by having access for everybody in the country on a comprehensive set of benefits with no co-payments. Certainly a lofty goal. How's it going in the case of GEMS? And I wanted to reflect a little bit. We've been the actuaries for GEMS for a long time now, and I've watched the scheme go through its waves of solvency pressure, solvency building, weather the storm of COVID, and this particular area of co-payments is something that the scheme pays a lot of attention to, and gets addressed every year in the benefit cycle review. As every year, the scheme undertakes a comprehensive review of benefit changes to contemplate its contributions and benefits for the following year. This year, there were well over 100 benefit changes that all individually had to get priced, costed, clinically checked, go through a very robust process to consider with 2023. And part of that review is a detailed consideration of out-of-pocket payments. So every year there'll be an analysis to identify areas where there are significant short payments, which claims are part paid or rejected, what's the reason, did people run out of limits, how did a change that we made last year pan out? And then there's a process of clinical and actuarial sense checking to say, well, can we enhance this benefit? Can we increase this limit? Can we add a benefit? Can we add an extender? Can we change the benefit structure? Can we improve network participation so that out-of-pocket payments are reduced? Of course, the process would love to say, well, yes, we'll just tick all the boxes and add all these benefits, but then again, there's the unavoidable effect of contributions increasing faster than inflation, certainly faster than salary inflation. So all of these things need to be balanced against the other. We have seen consistently over a 10-year period that GEMS has enhanced benefits to lower out-of-pocket payments for a very wide range of benefits, both in response to what we see in the data and the analysis, but also in response to member queries and engagement. On the non-CD electronic condition benefits have been enhanced, acute medicine benefits have been enhanced, over-the-counter benefits, pathology, psychology, prosthesis, etc., etc. All of the benefit categories get reviewed, and the majority of them get above inflation enhancements and benefit additions over time. Over the last 3 years alone, this has been an increase in benefits to reduce co-payments of 1.3 billion rand back to members, which we think is very generous in the case of GEMS over this period in a financially constrained environment. And really that bears testament to the degree to which GEMS has been able to affect other risk management initiatives and keep contribution increases affordable while still improving access to benefits over time, so that this money, so this 1.3 billion rand, would have been 1.3 billion rand higher co-payments for GEMS members, which has now been part of the risk pool as opposed to being taken out of pocket. Looking ahead, this process will continue. So every year there will be this process of reviewing out-of-pocket payments as an integral part of the benefit design process. Importantly, from my perspective, it's an area of the industry I've been involved in for the last 15 years, is trying to find better ways for funds to contract with providers, doctors in particular, through networks, DSPs, much more holistic contracting, which improves efficiency. And again, that the money saved there can be used to reduce out-of-pocket expenditure. We have seen strong moves there, and Dr. Stan mentioned earlier the success that the EVO option, for example, has shown in lowering cost and improving access because of smarter contracting and strategic purchasing. Member education is something that's been spoken about a lot today. A lot of those out-of-pocket payments could be mitigated through member education by understanding the co-payment happened in this case because you weren't aware of using this particular network provider or this particular medicine on the formulary or going through this particular care pathway or protocol. And part of that is the information asymmetry. It is difficult, but we need to do more to educate members and also providers to minimize out-of-pocket payments there. And then more and more strategic purchasing. I mean, it's really still in the early stages in our environment, but what is encouraging is we are seeing much more progressive adoption of non-fee-for-service engagements, more fixed fees, more per diems, global fees, value-based care kind of contracts where there are kickers for improving outcomes, team-based reimbursement models for doctors that are not so fee-for-service orientated. And it's encouraging that we're seeing more and more of those. I just want to spend a little bit of time on my last slide talking about this progressive contracting with doctors, because in the case of seeing specialists in particular, this is a pain point for many people in the private sector, because what's happened over time is there's been a growing differential between the price that specialists charge and the base rate of scheme tariffs that schemes are prepared to pay. This is the reason really that there are these so-called gap cover or medical shortfall products out in the market, but they're really a plaster on the system. They don't really solve the underlying problem of this divergence between charging and paying. And of course you can buy an extra product, but that, the question is, why not just increase medical scheme contributions by the amount of the gap cover? If there's just extra money in the system, it doesn't fix the inherent problems in the system. And that's where we need to spend a lot more time. As I say, this is a keen area of interest for me, and I think we haven't done enough to work together between schemes and specialists to unlock inefficiencies in the system, of which there are many. I'm not denying the importance of primary care here, because otherwise Morgan will say horrible things about me later on. But all through the supply chain, all the way through the primary care process, the rate at which patients are able to access specialists directly, the rate at which patients are referred to specialists, and then the costs associated around specialist care. Depending on the kind of specialty, there's a 5 to 10 times downstream cost multiple when you see a specialist. If a specialist is charging you 1,000 Rand or 2,000 Rand, the downstream costs from testing, scanning, hospitalization, medicine, etc., are 5 to 10 times what the specialist is charging in that case. There's a lot of room to improve efficiency and use that money gained to enhance benefits for members, particularly in this case. But what it requires are things that are difficult. And this is why we haven't been able to really put this issue to bed over the last 10 or 15 years. It needs trust. And we know that there are pervasive trust deficits in our market in any direction between funder and provider, public, private, et cetera, et cetera. It requires persistence. I've seen many of these fail because it's difficult. These are multi-year engagements with lots of different complicated stakeholders. The conversations are difficult, and it takes a long time and effort to get there. But it's possible to get there with sufficient persistence. It requires an alignment of interest to say we're in this together. It's not just every person for themselves to maximize their extraction out of the system. We'll all do better if we can work together and have aligned interests. Patient centricity is critical, as has been the theme for today. At the moment, it's the patients bearing the brunt for an inefficient system through high contributions, non-ideal outcomes, and high out-of-pocket payments. And then lastly, you really need the right tools. I mean, the system is complex. You need, whether it's benefit comparability, or tools for proper analytics, patient stratification, alternative reimbursement models. There's an investment that's required to build the right kind of tools so that you're equipped when you're having these kind of engagements. And we sit at many of these tables, and sometimes they break down because there's not adequate tools to understand the data, to make use of the data in a way that can be crafted to these more progressive models that will improve efficiency, and then over time lower the out-of-pocket payment to patients. So I haven't gone into too much detail in the limited time. Each of these sort of themes would require 10 or 15 minutes of their own, but perhaps there'll be questions later that we can get into at need. Thank you very much, Stan.
Thank you very much, Barry. And we are already receiving questions from our participants. So thank you so much for sending them. And thank you for sending them the way you're sending them, by indicating the name of the person that you're directing that question to. As I said, towards the end, we are going to give you an opportunity to have your questions answered. Thank you for that comprehensive presentation, Barry. And I think I get it a lot when I hear my mom complain about some of the stuff, and I'm like, but do you know about your benefits? And I think, as Mapato also emphasized, the need for education around the benefits that these patients are enjoying from the medical aid. So Mapato earlier spoke about the need to follow through the experience of patients. And our next speaker is going to address performance outcomes, patient-reported experiences. So let's welcome Dr. Beth Vale, who is an anthropologist and public health specialist from PESAT, who is going to speak on that.
Thanks so much. Am I audible? Am I audible? Can you hear me? I'm just waiting.
Yes.
Oh, there we go. Am I audible now? Okay, great. Seems like everything is fine. Perfect. Thank you so much. And thank you, Barry. That was a great primer for what I'll be talking about today, which is measurement. And just to jolt your systems, there's going to be very few numbers in this presentation. Instead, I will be starting with a poem, actually. So this poem is called Water, as you'll see. And it reads, they say your body is 60% water, your bones 25. By the time you're thirsty, you've lost 1%. I don't know who they are or how you create a fact, but I do know that I long to be a river, soft liquid for my bones, carving out rock to make a home. I know my deepest self is supple and unwinding, that my body recognizes what it's part of. And in this poem, I think is a really powerful message about what is often a gaping sort of gap between patient-reported outcomes, how patients experience care, and the way we measure and often articulate clinical outcomes. So for example, this line about they say might be a good way to articulate that when I'm in a health facility, knowledge about my body and my condition is created by external experts. Here, when the author talks about how they don't know who they are or how you create a fact, could reflect how the story of my health is written by strangers in impenetrable languages. We can't find ourselves often in those languages. What I know, that is the patient's expertise, what matters to the patient, what they value often remains submerged. The way in which this poet's body is supple and unwinding, which might represent the past and future and daily work of the health seeker's body, outside of this particular care episode in the hospital or the clinic is often invisible. And then finally, the patient's body and what's happening to the patient's body is often severed from the external world that the patient is a part of. So the difference between viewing this as a patient rather than a whole person, and hence the increasing move to talk about person-centered care, human-centered care rather than patient-centered care. We've started to play with the language of health seekers, given that patient often, you think of a patient often as being in a submissive position, which has also come up today. And so what this can look like in practice is you have clinicians and providers where what matters to them, the kind of version of your body is 60% water, might for a diabetic patient be something like the reliability of the patient's LDL cholesterol or their HbA1c levels. That means very little to the patient, right? So in the language of longing to want to be a river, what matters to the patient, they're interested in what likelihood they have to lose their vision, whether they're going to need dialysis, whether they'll have a heart attack or stroke, or need to undergo an amputation. And sometimes this is a matter of clear and sensitive translation of clinical language to language and story that actually matters to the patient. But sometimes it's really about a reordering of the way in which we deliver care. So this quote on the left comes from a community health worker in Blukenbos on the outskirts of Kraaifontein. We did some field work, community health workers supporting patients on HIV treatment. And it really is a powerful example of how what we measure can orient what it is that we end up valuing and shape how care systems unravel and fold themselves around those measures. So in this particular ward-based outreach team, supervisors had told community health workers that what really mattered about their work was the number of visits they were able to get in every day, the number of visits to patients' homes. And so community health workers found themselves running around often massive areas to reach as many patients as possible. And obviously that focus on quantity means that they can spend less time with patients. It also meant that there were times where a community health worker found absolutely no one at home, but still marked that down as a visit because they had been to the house. And so what becomes your metric of success is not aligning very well to the delivery of quality care. And the community health workers knew that, right? So here the community health worker says that the most important part of my job, they, the supervisors, say it's the visitation. But the most important part to me is not about the visits, but how well the patient is doing. So as many of the prior speakers have said before, a core problem we're facing in our healthcare system is rising cost and massive variation in quality, right? And what we really want to do is to try and shift away from a supply-driven healthcare system organized around process, what healthcare workers do, towards a patient-centered system organized around what health seekers value. And so we're there shifting from volume and profitability of services to really a focus on the patient outcomes that are achieved. Here's another example from the work we're doing at Percept in maternity care. On the left is a good indication of what the sort of standard measures are for maternity, things like your prenatal care utilization, C-section rates, morbidity and mortality, postpartum hemorrhage. And this is not to say that these things are not important, that these process and clinical measures are not important, but they have a bidirectional and interdependent relationship with how the health seeker themselves is experiencing care, in this case, how women and moms are experiencing care. On the right are a series of quotes that came back from some primary research we've done with moms across South Africa. We talked about what really mattered to them in labor and in birthing. Here they're talking about needing to have a doctor who was familiar with their case, right? Speaking to the importance of continuity of care. Some said it was important for them to have their birth method explained to them. Patient information, the shared decision-making that's already come up today, wanting their partner to be present in the room, wanting their supporters, wanting the family to be around, that's also come up today. But these things on the right are often not measured. And what then is also not measured is the relationship between those patient-reported outcomes and the clinical outcomes or process outcomes that we see on the left. So what I've been sort of intimating already here is these ripples of value. And at the center, we see often these core categories of patient-reported outcomes: their experience of the care that they're receiving, their quality of life, including their psychosocial well-being, their mental health, their ability to get through their daily activities with ease and with support. And then of course, their functional status, their level of recovery, their pain, for pregnant women, incontinence, for example. Once you have all those interrelated things measured and you can track them and then provide targeted support in response to patient needs, that creates a kind of reinforcing value chain with the ability to give patient responsive care, which in turn is likely to make people use that care more, improve health outcomes, and so the cycle of virtue continues, right? So in the current measurement machine, there's a lot that's silenced. I've already suggested that part of what is silenced and submerged is an understanding of what patients or health seekers themselves really want, what matters to them. We also often don't hear the story of how those people experience the care they receive and how that experience of care is shaping their recovery trajectory, shaping those clinical outcomes, shaping their utilization of care, shaping the quality of care. And then we also miss a lot of the very meaningful caring work that our frontline health workers are doing. Their role as translators between the clinical and the person, between different levels of health providers, their role as cultural mediators, as educators, all of that has huge effects on the quality of care and how patients experience care, but often goes unmeasured. And we know, of course, that the less we measure these things, the less likely our systems are to orient around them. So what becomes possible if we start to really pay attention more closely to patient-centered measurement and person-centered measurement? We surface best practice, what is emerging as best practice for delivering more consistent outcomes and outcomes that matter to patients. We start to rebuild trust because healthcare workers are suddenly being able to align their performance goals with their sense of purpose as a professional. We empower health seekers to drive quality and competition in the health system. So with information that actually matters to them, with knowledge of the outcomes that matter to them, with knowledge of which providers are being able to meet the standards of success that those measures imply, patients can then start to make choices and drive up quality and competition in a bottom-up way. And then we reduce cost, as Barry was talking about, by empowering providers to make those data-informed decisions that enable quality care, get rid of a lot of redundancies and duplication. And you're also empowering payers to pay for services that achieve those results. So many people already today have talked about value-based care. This is one way of reflecting what value-based care is, which involves these components of measuring, delivering, and paying. And the measuring is central, right? Because with the paying, what you're doing is you're paying for value, which is the value as articulated by the measures, to incentivize that continuous improvement. And in terms of delivery, you're delivering value by using data to learn and improve performance. And of course, the overall goal of a value-based approach is that you end up with the best outcomes as defined by the health seekers at the lowest possible cost. That becomes your definition of value, right? But as Barry quite rightly was saying before this, it's no easy feat to shift towards a value-based care model. It demands quite significant and courageous change. We're moving from a clinician-centered, profit-centered, fee-for-service or global budgets model towards something quite different that's going to require new ways of working together and often new ways of collaborating together. We have a regulatory environment, just as an example, that is often not attuned to the needs of value-based care. So for example, our current regulatory environment doesn't leave a lot of room to pay for multidisciplinary teams, for example. And our structure for sort of seeing value-based care organizations is still within the framework of managed care. So there's an ecosystem that needs to shift. And it's very difficult to shift that ecosystem alone, which is why building a community of practice is so important, because that community can have conversations with regulators, for example, with much more power than one value-based care organization or one value-based care provider. So I really see today already as an opportunity for us to build and strengthen that community of practice, the values that we hold dear, to align our incentives and to take courage, to take imagination, to potentially lean into the poetry, to reimagine the numbers. And I really am just grateful for this opportunity to be in conversation with all of you. Thank you.
Much, Dr. Bale. Thank you for that poetic presentation around a human-centered care. Our next topic is on advancing women's health. And to discuss this, we have Nyawira Jeru, who is all the way from Kenya for us. And she's the head of market access and government affairs at Africa Hologic. So Nyawira, thank you for joining. Over to you.
Great, thank you very much. I believe you can hear me. Give me the cue that you can hear me. Fantastic. So thank you very much, James, for inviting me to speak at this meeting and really speak on a matter that is truly very dear and close to my heart. The previous speakers have actually set up the scene very well, discussing women's health, why we need to measure, why we need to understand what is happening for us to be able to program in a better way our programs and care. I would actually want to argue that the Deputy Minister, when she spoke, did run away with my presentation, right? She really did articulate the need for us to focus on women's health, and particularly highlighting the burden of breast cancer and how it is really draining the pockets of many families across the continent. So I do hope that I'll be able to add more context into that initial discussion, sharing with you what we are doing at Hologic and why it is important to continue to invest in preventive care, specifically as far as women's health is concerned. I don't seem to be able to advance my slides. Great, thank you. So when we think about women and across the continent, we know that 50% of Africa's population is really women. In South Africa, it's about 50.8%, which is basically about 51%. We have about 230 million women of reproductive age, and therefore they are a cohort of group that we cannot ignore when we think about our healthcare programming. And we know that women in this continent really do represent 50% of our human resources, and especially within healthcare, we do know that women contribute 70% to the global healthcare workforce. Some other details that are very important is to know that 1 in every 4 deaths among adult women is related to a non-communicable disease. And in this case, we're talking about not just cancer, but also heart disease and diabetes. We know that previously we have thought that cardiovascular disease affects more men than women, but we are seeing that it also does affect a great number of women as well. And finally, as mentioned in the opening remarks, we know that breast and cervical cancer remain the #1 killer cancers among women. This in itself then sets up to say, why should we be investing in women's health? And what are those things we need to do from a prevention perspective to ensure the health and well-being of women?
Nyawira, can you unmute yourself?
Sorry, did I go on mute? I don't know where I lost you. So if we reflect on the disproportionate burden of disease within the continent, we can already begin to see that breast and cervical cancer are really the #1 top 10 cancers within the continent. Again, we do know that these two cancers largely do affect women. We do know as well, as far as inequities and access to care is concerned, that when we compare Africa and the high-income countries, we do know that 4 out of 10 women diagnosed with breast cancer in South Africa will actually die within the 5 years of having been diagnosed, as compared to higher levels of 6 or 9, 6 in India and 9 in the high-income countries. And it is this proportional burden of disease, as well as the inequity in access to care, that then makes us want to continue to invest solidly in preventive care so we can continue to ensure the well-being of our women. Continue to become part of this dialogue on championing women's health today and into the future. Hologic is a medical device company who is heavily invested in providing solutions that do impact the well-being of women across the continuum of care. We do see ourselves as being positioned to begin to drive advocacy and the dialogue around fundamental investments to improve the well-being of women and families globally. Next slide, please. Am I able to control the screen? I'm finding it a bit difficult to keep switching, and for some reason, I'm not able to move the slides from my end. Sorry for that technical challenge.
Hi, Nyawira. You can just click on the screen and then you should be able to advance with the arrows on your keyboard. There we go.
Okay, this is now what? So either I'm moving the slides or somebody else is moving the slides, because this seems to be moving differently. Okay, so here we are. Thank you. So in terms of our solutions that are focused on women's health, we want to support women along every stage of their journey, beginning from sexual health, also looking at breast and cervical cancer, but also looking at body composition, focus much more on bone density for early detection and diagnosis of osteoporosis, which we know disproportionately does affect women. But beyond what we do in our solutions, we're also investing heavily in digging a little deeper and getting insights that then enable us to say, how do we respond to the needs and changes that women experience through their lifetime journey? And to that end, Hologic has invested into what we call the Hologic Global Women's Health Index, which is a multi-year survey, comparative survey, where we partnered with Gallup to be able to get the insights and voices of women as they do experience care within the setups where they seek care. Beth did set this up very well, discussing that one of the key components that we must be measuring is how our patients are experiencing care. And that is what we hope to bring out in the context of the Hologic Global Women's Health Index. So what are we able to unearth out of the Hologic Global Women's Health Index? In the first year of the survey, which was 2021, and in partnership with Gallup, we were able to interview 120,000 women and men as well in 116 countries across the world in over 140 languages. In Africa specifically, we were able to collect data out of 24 countries, of which South Africa was one of them. And the whole goal here was to evaluate the knowledge, attitudes, and behaviors of women as it relates to health. So when you see this data, it's a reflection of the perceptions of the women and not necessarily what the countries or governments are actually offering. It is how they perceive care where they do receive it. We focused on 5 critical areas, which is non-communicable diseases, their experience, of course, with the healthcare providers, prenatal care, emotional health, as well as domestic violence, because we do know that these 5 do have an impact on the well-being of women. So in the first year, we did come up with what we call the 5 dimensions that really do impact the well-being of women and actually can explain 80% of a woman's average life expectancy at birth. And the key recommendations that did come out of this initial survey was for us to begin to move the needle on women's health. We needed to invest in 3 key areas. The first being able to detect deadly diseases early, and this is where prevention comes in. The second is protecting girls by keeping them in school. We do understand that by educating women, we are actually building better for society. And the third piece was keeping women safe at home. And this is in relation to gender violence, which of course has a physical and emotional impact on women. If you can see to the right-hand side on the 5 dimensions and how these correlate to life expectancy, you can see that countries that scored higher on the Holistic Global Women's Health Index do have a higher life expectancy. Japan at the farthest end does show that. And if we take South Africa with a minimum score, an average score of 55 out of 100, we see that life expectancy is actually about 68 to 70 years for women within South Africa. So this correlation then lends credence to the fact that women's perceptions on their health issues truly does drive their well-being and better health for them. So just a brief snippet into the initial findings, and I just want to focus a little bit on South Africa because this is where we are today. We will see that the average score for all the countries surveyed was 54 out of 100, which means that there's still a lot that needs to be done across the globe, not only within our continent. Taiwan was an outlier, scoring just about 69 out of 100, and the highest score in Africa came out of South Africa with 55 out of 100, although South Africa was ranked number 50 out of the 116 countries that were surveyed. But globally, one of the things that we're able to establish is that the world is truly weak on preventive care, and this is an area that we need to begin to focus on and invest in. And here, we did hear that over 1.5 billion women did not receive any screening for what we call the 5 major diseases that do affect women. And this is high blood pressure, cancer, diabetes, and STIs as well. Specifically for South Africa on preventive care, South Africa had a score of 43 out of 100, and you were ranked number 1 out of 23 in Africa, which I would say is fantastic, knowing that this cause and this survey was actually conducted during the height of COVID back in 2020. At a global level, as far as basic needs are concerned, we do know that women are still struggling to meet their basic needs. However, in the context of South Africa was rated number 51 out of 116 countries with a score of 68 out of 100. Again, investing in women empowerment, the ability for them to be able to provide basic needs does have a significant impact on their well-being and on their health. On individual health, South Africa was ranked 84 out of 116 countries with a score of 49 out of 100. And when we talk about individual health, is really the aspect of, are women living with a condition that is keeping them in pain and also impacting their ability to be able to go about their day-to-day work. And here again, you can see a score of 49 out of 100 for South Africa. So in terms of having access for screening and testing to any type of cancer, and here this is not just breast and cervical cancer, globally, only 12% of the world reported, of the world's women, reported having received any screening for any type of cancer. In the context of Africa overall, we had 11% across the continent, whereas the global average was 12%. But we do see higher scores in Zambia and South Africa, where 29 and 25% of women respectively did say that they had received at least screening and testing for any cancer in the 12 months preceding the survey. Reflecting on the fact that the cancer is becoming a heavy burden in the continent, it's then important for us to say what more can be done for us to continue to improve access to preventive care, early screening and diagnosis of these ailments that we know are totally draining the financial pockets of most families. I will skip the one on STIs and basically come and look at the real correlation between universal health coverage and the ability for patients to be able to see a doctor at least once a year. The previous presenters have actually talked about access and affordability and cost. And one of the critical things that we find is that where cost is an issue, more often than not, women do not go to see the doctor. They do have to make a trade-off between putting food on the table or actually being able to go and pay for a service that is purely for screening, sometimes for a disease you do not have symptoms for. So what we see here in this correlation, and this is based on the WHO Universal Health Coverage values, is that countries that increase investments in health then do provide that access for more women to be able to see a doctor. So creating access, whether it is through cost and affordability, or also having more doctors, patients, healthcare workers available, it does then mean that women can access the care that they do need at any point in time within their life's journey. So what will happen if we don't do anything? And I specifically want to spotlight breast and cervical cancer because these are the top two cancer killers, but also this being October, it's also Breast Cancer Awareness Month. If we don't do anything to change the tide, in Africa by 2040, the cases of breast cancer will actually double and cervical cancer will increase by half as well. So the question is, what are some of the things we can do to begin to invest more into preventive care and enable healthier lives for the women of the continent and specifically also within South Africa? And a lot of those things have already been mentioned by the earlier speakers. And I would just want to highlight the three. The critical piece is awareness. We have had a lot about information and education, ensuring that women and girls do have the information, they understand the need to go in for screening and testing, and creating that generational awareness. So starting as early as adolescent girls understanding the need for sexual health and also for them to go for sexual infection screening, but also moving into the mid-years when we do cervical cancer and breast cancer screening. So bringing that information and putting it into the hands of women is one critical space for us to be able to close the gap. The second piece, and Dr. Beth did really bring this forward, as well as the previous presenter, is on access. And access here is twofold. It is twofold in terms of being able to create the environment where women can actually be able to walk into the centers and be able to access care. Bringing down the cultural barriers that deter women from being able to access care. The second piece is establishing structured screening programs. We do see a lot of activity happening ad hoc across screening programs. January is Cancer Month, February is Cervical Cancer Awareness Month, and October is Breast Cancer Awareness Month. In these months, we are heavily investing in creating awareness, but in between, for the rest of the year, what exactly is happening? I would say the challenge here is for us to establish structured screening programs and move away from these ad hoc screening programs that we are only doing once in a year within these specific spotlight months that we do focus on particular disease areas. And the second piece is on affordability, and this has been very well covered in terms of the cost structures and what needs to happen. Universal health coverage is one pathway that can actually be explored, but the other part is to look at reimbursement programs for screening, for vaccination as well. In my country, and I like to share this story, today, if I wanted to go in for cervical cancer screening and I want to get the human papillomavirus test, I as a woman would have to pay for it out of pocket. But my husband gets to get the PSA, prostatic specific antigen screening test done for him free of charge as a blood test. Now that disparity in itself means if I was not a woman of means, I'll not be able to get an HPV test, whereas my husband does have access to a PSA test. And we need to be able to look at reimbursement mechanisms that also do cover testing and screening tests for women. And then finally, some of the interventions that we can be looking at in the whole journey of a woman. I've already talked about immunization programs, being able to reimburse or cover immunization. So we're preventing diseases so way much earlier when we have the opportunity to. For the adolescent girl, we are also advocating for coverage and also reimbursement for the HPV immunization. We do know that cervical cancer the cause of cervical cancer, 90% of cervical cancer is as a result of the human papilloma virus. So being able to immunize our girls much earlier then means that we are preventing them from progressing into a potential cervical cancer in the future. In the reproductive ages for women, we're also talking about integrating STI screening and testing beyond HIV, which we know has been very well covered and supported across the countries. So here we want to add chlamydia, gonorrhea, and trichomonas infections as part of the screening program for women. And then of course, cervical cancer as well as breast cancer. And in the later years for women, we are looking at screening for chronic non-communicable diseases. This is heart disease, hypertension, diabetes, and of course, not ignoring cervical and breast cancer. This holistic approach can actually be employed and looking at it from an age perspective, covering from childhood to adulthood and the later years would then enable us to be able to support a healthy nation, a healthy continent by ensuring that our women who are really pivotal to our society and social being are well taken care of. So why is it important for us to continue to focus on women's health and really focus on preventive care? I did mention that women remain informed in their home with our communities. They do represent 70% of the global health and social sector workforce. So they are an important aspect of our population. They are a critical segment because they're part of economic recovery and growth based on the socioeconomic activities that they are engaged in. And I do believe that if we are able to just put in about 10% of the efforts that we have put into COVID today, we should significantly be able to move the needle insofar as women's health is concerned. At a global level, we do know that women's health is a global issue, and it is the cornerstone of families and communities, societies and economies globally. And if we truly want to build better post-COVID, then truly improving women's health empowers them to continue to support our economic growth, support stronger families, which means more income, and it can mean more thriving societies and economies. Thank you.
Thank you very much, Nyawira and Jeru. What happens if we don't change the tide? And that's the question that she's asking. And it looks like the situation will be dire. There's a lot to do to invest of women, not just from the access to the healthcare services point of view, but just affordability and also the experiences that these women have at the healthcare services. So that investment is important. And also just the implementation of the interventions that Nyawira and Jeru was about. There's certainly a lot to digest. So how about we take a 5-minute comfort break just to stretch those legs. If you need a bathroom, when you step out, just to your right, participating virtually, I'm sure you know where to find your bathroom. So 5 minutes, we've been right on time. So let's keep it 5 minutes and we'll continue with the next segment.
Yeah, I can add on the notes. It's on my headset. Whose headset are these? So just check now. Ibhalwe one. Zama. Uyazi one i1 this one.
All right. Can we settle down and get ready to continue? There we go. Thank you very much. It was a comfort break, not a lunch break. I used to do that a lot. I was studying recently, and every time the lecturer used to give us, because we attended virtually, and she comfort break, and because I'm a bachelor, I cook. During the lessons, when they give us a comfort break, I would quickly rush to the kitchen to make eggs. Mind you, that's in the evening. Because what else can I cook? And I would make eggs, and sometimes I'd forget to mute myself, and the lecturer will know what's happening in the background, and I would have to explain that I was quickly making eggs. Welcome back. I think we had a good start this morning. We are right on time, and now we're just about to get to our second segment. So without even wasting any more time, please help me welcome Dr. Vuyo Kola, who's the Chief Healthcare Officer at GEMS, who will take us through this eco-value co-creation.
Every minute, somewhere, someone is involved in the abuse and waste of healthcare services or is committing fraud against the medical aid sector. Common types of healthcare fraud, waste, and abuse include false statements that can result in unauthorized benefits or payment, extra costs incurred when healthcare services are overutilized or when claims for services are prepared and submitted incorrectly, or actions that are improper and inappropriate outside acceptable standards of professional conduct and result in unnecessary costs to a medical scheme. Medical aid fraud accounts for over 22 billion in lost revenue each year. GEMS has paid more than 200 billion in claims to over 40,000 healthcare providers since 2016. These losses drive up your premiums and make the system less efficient. You can avoid being a victim of healthcare fraud by keeping an eye out for fraud, waste, and abuse signs. Signs include decreasing benefit levels for services you haven't used, illegal agreements between members and providers to get cashback or other incentives in exchange for a claim, or paddling claims by always charging the same tariff combos. You should also keep your personal medical aid details personal. Always check your monthly statements to make sure that all claims are correct and that you receive the services that have been claimed for. Ensure that you and your family only use the healthcare benefits when it is completely necessary. If you see or suspect any suspicious fraud activity, report it to GEMS immediately. Call the anonymous 24-hour toll-free GEMS fraud line service on 0800 21 2202 or email office@thehotline.co.za. You can also SMS short code 30916.
Okay. Is it still, it's still morning. Good morning to everyone. It's such a pleasure being part of the symposium. I've missed the last two symposiums, I think, due to studies. So it's exciting for me to be part of this once again. I know that there's a lot of turnout in the virtual platform, and it's really exciting for us. I do hope that it's not just colleagues from the funder industry, and I hope that there's also colleagues from the healthcare provider industry, because we really need to, and these are important conversations that we're having today. And I really hope that, you know, from this or after these conversations, we're really going to work together and collaborate more in terms of moving towards a more efficient and sustainable healthcare system. So before I start, Clement, I was not as lucky as you. Unfortunately, I wasn't a GEMS baby. I'm not gonna tell you what baby I was. That's a conversation for another day. I don't want to get in trouble. But in my previous life, I used to work as a medical advisor for one of the GEMS service providers, and I was in the GEMS business unit. And my colleagues and I would always say, oh, you know, we wish we could be GEMS members. So I'm happy to say, Dr. Sten, I've been a GEMS member now for over 7 years. So, so I'm really here to talk the talk, walk the walk, walk the talk, walk the talk. So as I start my presentation, I think the previous speakers have alluded to this. We do know that I think we can all agree in this room that we've got a healthcare system that really is characterized by tremendous inconsistencies as well as fragmentation. Mabato spoke about, you know, some of the recommendations, some of the findings from the HMI, talking about a fragmented healthcare system, hospice-centric healthcare system, and the healthcare system really that is lacking in terms of value-based purchasing. So, and I think we can all agree that we really need a healthcare system that is more sustainable, that is cohesive, and that will really serve our patients better. I'm going to be speaking about patients today rather than members, and I'll be using probably interchangeably both of those words because I do know that there are practitioners here as well as funders. But just to show some of this fragmentation that we see in the GEMS space, in the primary healthcare space, for example, we find that about 50% of our members consult with one general practitioner. However, 33% of these members we find, 33% of our members we find that consult with more than one general practitioner, and even more concerning, there are some members that consult with more than 3 and up to 6. And this is obviously very concerning because the care is not coordinated. There's overutilization and repetition of tests and a lot of wastage there. What we also see is that only 1/3 of our members would actually go to a GP before they actually consult a specialist. And the rest will just directly go to the specialist and bypass the GP. This is obviously an issue, especially as we're moving towards the realization of universal health coverage, because the referral pathways are really not as they should be. What we also see is significant variations in terms of how care is delivered between various geographical areas. And I'll just make an example of the map that you see on the right-hand side. If you look at Limpopo, Limpopo has got a risk-adjusted hospital admission rate that is 30% below average. But if you look at the Northern Cape, it's 36 above the national average. And those are the two extremes. But you can see the variations between the various geographic regions. This is, of course, concerning because clearly there's inconsistencies in how we are delivering healthcare. And this speaks to really either overutilization or underutilization of services, which is a huge concern. And of course, we know about COVID, the great disruptor. It's as if we didn't have enough problems in our healthcare system before, but with the COVID pandemic and the lockdown regulations and the decrease in healthcare seeking behavior, we found that the pandemic has really had a huge impact in terms of disrupting, not disputing, disrupting the normal healthcare seeking behavior. And it's worsened the situation that we had in terms of inconsistencies in healthcare delivery as well as fragmentation. Just to share some of the experiences that we've seen in the pre and post-COVID period. We're looking at now 2022, and we compare it to pre-COVID, to the pre-COVID era. We find that in the primary healthcare space, we are still seeing a reduction in primary healthcare consultations like GPs and dentists. In the hospital space, there's still a reduction in surgical admissions as well as medical admissions. And we were hoping that by now we would have recovered slightly and would have seen almost us going back to the pre-COVID era, but that's still not happening. Even more concerning in the preventative and screening services, and I'm saying even more concerning because we come off of a very low base, even though these services are available, but we find that the uptake is very low. So we're really concerned about the fact that there's still a decrease in the reductions, a reduction in the screening services like HIV and mammograms. And we're hoping really that we go back to I think the utilization, do much better even than the utilization we had before COVID. With regards to diagnosis, we're still seeing a decreased reduction in cancer diagnosis as well as a reduction in acute myocardial infarctions. And this is obviously concerning because members are not really getting the access to care that they need. We are worried, of course, late cancer diagnosis will only lead to poor outcomes and poor prognosis. So with this being said, we really need a way of shocking our healthcare system back into rhythm and actually improve even to a status that is more coordinated or better coordinated than it was prior to the COVID pandemic. A few of the speakers have spoken about, value-based purchasing or value-based care. At GEMS, we've adopted a way of healthcare reform through value-based models or value-based care. At the center, we always put the patient first or the member first. We are all familiar with the value equation. What I like about this diagram of the value equation is that I think as funders or clinicians, when we talk about outcomes, we really focus on clinical outcomes, but we don't really necessarily pay attention to the outcomes that matter to the patients. And I think the slides really illustrate that we also need to look at not only the outcomes that we want, but also what matters to the patients when it comes to quality. When it comes to cost, Barry spoke about the out-of-pocket expenses, but we also need to realize the impact of some indirect costs that the patients might incur, like, for example, the amount of or the distance that someone has to travel to get access to healthcare services, or really the impact that time away from work takes from the patient from a cost perspective. So there's various ways, and some of them have been spoken about today. There's care coordination, a multidisciplinary team. And we know that there are some regulatory constraints in terms of establishing true multidisciplinary teams or integrated care, but it can be done, and I will be sharing some of the ways in which we've been doing that. We need to really focus on preventative care, primary health care, and screening services, and this is in line with universal health coverage. One of the things that we really need to, and I'm glad that there are healthcare practitioners in the room, not in the room, in the virtual space, is that I was at a conference recently, and one of the things that one of the providers spoke about is how we as funders, we tend to have, we talk about measuring outcomes, and but we don't collaborate, and we don't talk about what are these standardized outcome measures that we want to see. So can you imagine if you are sitting as a provider out there, you've got GEMS, you've got Bonitas, you've got Discovery, and you have to really align to all these outcome measures that you're supposed to be contracted on, and your performance is based on that. So we really need to come together as an industry and have standardized outcomes that we all measure together, and really make it easier for providers to really do what they're supposed to do. With value-based reimbursement models, I'm going to share just a little bit of what we're doing in the GEM space. I think the next part of my presentation will really focus on what GEMS is doing. We are working towards the realization of value-based care. As I mentioned earlier, Dr. Stan spoke about walking the talk. So I guess these are some of the examples. Unfortunately, because of time constraints, I won't be able to share all of them, but we would like to share some of the initiatives that we've got going. Some of them have been mentioned by Dr. Stan and by Barry, but I will elaborate on a little bit more of what we're doing. So in terms of care coordination, I think everybody is familiar with our two flagship options, Emerald Value and Tanzanite One. Both of these options are premised on the principles of care coordination. There's really referral pathways that are put in place, and this is in line with the principles of universal health coverage. With Tanzanite One, which is our basic benefit package, or at least our version of what a basic benefit package might look like. Some might argue with us that it's too comprehensive or it's too rich, but nonetheless, it is our version of what a basic benefit package might look like. We've got unlimited GP visits. And really the emphasis there is to make sure that we promote primary healthcare services. By care coordination, we mean general practitioner nomination. And what we mean by that is we encourage our members to stick to one general practitioner as the gateway to all their healthcare needs. They only get referred to a specialist if the general practitioner has actually referred them. So there's no bypassing the GP. And then we make use of efficient provider networks as well as a hospital network, and we contract on quality and cost criteria with those providers as well as hospitals. I'm happy to say that both these options combined have got over 700,000 members registered, and over 93% of all the members on these two options have actually nominated a general practitioner, which means that they only have one GP that will take care of all of their needs. So what have we seen from this, or what results have we gotten from this? There's a significant reduction in cost overall per member per life expenditure. There's a decrease in hospital costs, a decrease in specialist costs, and an increase in GP costs, which is what we want to see, because we want members to utilize their GPs as their first point of care. When I showed this slide at a recent conference, I was challenged by a specialist, and they said, well, you know, specialist visits are very important. We're not saying that specialist visits are not important, but we want members and patients to access care at the right level. So really, there's no need for specialists to be seeing cases that would be managed by a GP. One of my classmates from my MBA program, who's a pediatrician, was complaining to me about how he sees snotty noses all day. And can you imagine, sitting there as a pediatrician and all you see is snotty noses and mild gastro cases that really could be seen in the primary healthcare space. So we're not saying that specialist visits are not important. The emphasis is on accessing care at the right level. So with all these savings with EVO combined, we see that there's over 850 million rands that we save, and these savings go back to the member. From a clinical process point of view, we see a higher uptake in screening tests, as well as process measures for disease management, as well as improve preventative care benefits uptake, which is good. And from an outcomes basis or clinical outcomes basis, we see lower admission rates and we see lower specialist visits. The lower admission rates we use as a surrogate outcome of, surrogate measure of clinical outcomes, because if you have less admissions, it means your condition is well managed, and you don't have to have as many admissions as you do. And in the chronic disease space, I don't have a slide that indicates this, but what we do see is that the members on these two options actually are much better managed if you compare them to the other options that are not network options, just because of the emphasis in terms of really focusing on coordinated care. Another example I would like to share with you is a pilot that we started in 2020 in Pretoria North. And we chose Pretoria North because we have a high incidence of high-risk beneficiaries there. And we implemented an integrated care population medicine pilot where members have access to a multidisciplinary team of providers. There was unlimited access. Members did not incur any out-of-pocket payments or expenses. Part of the multidisciplinary teams were nurses who acted as care coordinators. They engaged with the patients, they went to their homes, they coordinated the care amongst the various practitioners. We also had GPs, physicians, and allied health providers such as networks and dietitians and physiotherapists. And through this multidisciplinary and integrated care, we really saw, and I'm excited to share some of the results that we've seen from this pilot, but the idea was really to contract on a capitation-based fee. And we basically worked on a performance score that we used throughout the pilot to try and see to which extent this integrated care approach has improved in terms of costs and improved outcomes, of course. And I'm happy to say that over the past 2 years that we've been running this pilot, we've had a significant improvement in terms of the outcomes of this pilot. To be specific, there's the 30% improvement over time. So because of the success of this pilot, we have now made a decision to then integrate this program into the GEMS environment, which means it's no longer going to be a pilot. This is going to be open to any willing and able provider, multidisciplinary teams across the country. And I'm appealing to those that are in the audience, whether it be here in this room or in the virtual platform, that we really do have an open door approach. We want to engage, we want to really establish and roll this out. And we are ready and willing to engage and collaborate. And I do know there are certain regulatory matters that make some providers reluctant, but it can be done. And we would like to collaborate and roll this out even further. The last one that I want to share with you is an integrated care program for chronic back and neck rehabilitation. This is where our patients with chronic back and neck problems are referred to multidisciplinary teams that assist them in the rehabilitation of their chronic back and neck problems. The teams are comprised of physiotherapists, occupational therapists, as well as biokinetists, and the GP also is at the center center with some of these programs where they coordinate the care. What is also important is the fact that the patients engage and are educated in terms of how to proactively manage their back problems. We're happy to say that we've seen a reduction in hospital admissions, and this is in the case of conservative management of backache, which was a huge problem for us before we implemented this program. We also have seen either a reduced need for surgery or prolonged, at least the surgical intervention is prolonged by a few years because of this. And more importantly, the patients have really benefited for this. So our members have reported improved range of movement. They've got restored functionality in terms of their activities of daily living, and they've got reduced pain. So this is what I wanted to share with you today. And we are hoping, or I'm excited that we will share more of what we have seen in this space I hopefully Pumi at the next symposium. I hope there's no chemists in the room that are going to grill me about my last slide. Basically, I think in closing, I just want to say, you know, similar to the fusion reaction where you've got two nuclei that are bound together and release more energy, we are saying that we really need a nuclear fusion in the healthcare space so that we can really have, or we can really propel our healthcare system and coordinate it in order to achieve a more sustainable healthcare system. And as GEMS, we are striving to achieve this. There's many more that I wish if we had time we could share with you, but we look forward to sharing more in the future. Thank you very much.
Thank you very much, Dr. Ngola. And the question we all have, how do we create that more efficient and sustainable healthcare system? And Dr. Ngola was speaking about the and she spoke about the tremendous inconsistencies that exist in the system. And we need to make sure that that healthcare system is efficient, it's cohesive, but also is sustainable. And part of getting there is to improve the benefit design, which is exactly what the next topic is about, optimizing beneficiary choices. So please help me welcome Dr. Rajesh Patel, who is the head of Health Systems Strengthening at BHF.
Thank you very much for the invitation to chat. And thanks for asking me to talk on this important subject at play at stage. I think every October, most of us receive our member schedule from the scheme. And I'm not sure about you, but I sometimes have difficulty trying to interpret what's going to happen in the next year. And I've been in the industry for some 27 years and obviously have a medical background. And that's why I think this topic is absolutely important in looking at benefit design of a medical scheme. Are we ready to start with the presentation? Oh, I need to press the slide. There we go. Thanks. I think the critical component before we even talk of benefit design is understanding really what our business is in the medical scheme environment. And my personal view, and I know that this is the BHF view as well, is that the business of a medical scheme is not about managing money as a primary objective. That goes along with any of the business. But critically, the business of a medical scheme is looking after the health of the beneficiaries that are on that medical scheme. And I think in that context, BHF has recommended this definition is that the business of protecting, promoting, maintaining, and improving the health of beneficiaries by undertaking what's in the legislation, which is collecting money and paying money. So this is absolutely critical. And if we understand that this is our business, then that would shape a lot of what we have to do in the medical scheme environment. I think if our business is health, then we need to fully understand what healthcare needs are. If we start at the bottom right-hand corner for everyone, that's the current benefit design. It gives you a sense the size of the wallet really determines what kind of benefits you get entitled to. And then in 2000 came the PMBs. They tried to create equality. And unfortunately, there's still some members that are left behind out there. because of the nature of the PMB benefit design that was created, mainly diagnosis-based. If you have a diagnosis that's not on that list, then we offer you fresh air and love and fresh air. The ideal is obviously moving towards that equity box, and that is benefits on the basis of need when you need it, from January to December, not necessarily on the size of the wallet. The ideal scenario, liberation, is all that great. Unfortunately, in healthcare, we have infinite needs, but we have finite resources. And therefore, we have to ration. And unfortunately, we can't meet everyone's needs out there. So what we can only do is to try our best. But in this scenario, the best is to try and work towards an equity environment. So if you want to move towards equity environment, it's critically to start looking at what's happening around us in the world. And there are some nice gems out there that we can pick up. Sorry to use that as a pun. And the most critical is universal healthcare coverage. The first time universal healthcare coverage was punted was many, many years ago, and it started to gain a lot more prominence in the early 2000s. And there are three critical components to measure ourselves if we're making progress towards universal healthcare coverage. The one is increasing the benefits on offer. And I think you've heard earlier today about some of these changes taking place in GEMS. It's also about increasing the number of lives that are covered on the insurance platform that's existing out there. And the last and important component is the extent to which you have to pay for healthcare out of pocket. And we've heard the talk earlier about to the extent we're reducing out-of-pocket payment. These are three critical components to measure if we are making progress towards universal healthcare coverage. So if we really want to move towards an environment where we address equity and to create equity in our environment, there's actually two critical components to put in place. The one is the common benefit plan. It was first mooted in our environment in Circular 8 of 2006. BHF subsequent publication in 2007 incorporated this, but included an additional component, which is the details of that benefit that should be included. And then the health market inquiries report also came out and mooted this common benefit plan that needs to be introduced within our environment. And I'll talk a little bit more details about that in a few moments. But the reason why that Circular 8 2006 didn't really take off is because it had one missing component, is that if it was to be implemented as was proposed, then the impact on the low-income people would be quite adverse, and that their average contribution would have increased. And I think the solution came in if one starts including common health benefits with an income contribution table, irrespective of whether it's a closed scheme or an open scheme. And that's critical from a benefit design perspective, the direction we need to move. Which brings us to the next component. Once you've been able to design it, what kind of benefits do you fit into that package? And I think we have some direction provided to us. Unfortunately, it's been ignored by the regulator and government in the past when they came up with PMBs. And the first and most important is the Constitution. We read Section 27 very carefully. It talks about access to services. And that should have been a hint for us that we need to design our benefits along those lines. If we read all the universal healthcare coverage literature, there's specific reference made to access to essential service, essential medicines, and vaccines. That also then gives us a sense of what the content should look like as we move forward and the reforms that are needed in our environment. So literally, we need to move from a finance-centric environment to a health-centric environment. And I want to use an anecdote kind of thing. Many medical schemes have multiple plans. You have a low benefit plan, some middle of the range benefit plans, and a top of the range plan. Critically, the low income members would often fall into the category or take up the low benefit option. And those in the middle of the road, middle income or high income, would potentially be on the high benefit option. And literally, what the regulation currently says that each plan needs to be self-sustaining. So from an equity perspective and a social solidarity perspective, our interpretation is the low-income people need to cross-subsidize themselves, and the high-income people would end up cross-subsidizing themselves. And that's a total antithesis of social solidarity. And definitely we need to start moving away from the current benefit design that's out there at the moment, and that's been in place for the last century. So what kind of benefit design should we be moving to? This is what's been proposed a long time ago, as I said, from that Circular 8 of 2006. The issue then comes in terms of choice in this regard. This is the one where, unfortunately, we have to adopt the social autocracy route, where because of the complexity of health benefits, the healthcare services out there, you need some experts to guide what is essential and what should be core benefits. And then the top-up benefits comes in, let the wallet determine this, what options you additionally take up, and that we can leave at a democratic level. What is also interesting and nice about this type of package is that the subsidies that employers provide can then be directed towards this common benefit, which is designed in a way that will ultimately seek improvements in the population health. And that's what we need to promote a lot more of. And we'd like to see a lot more of it included. I talked about the content. That is the benefit design, how we should be structuring it. Now the question is, how do we determine what content should be? So the ultimate objective of patient and person centricity is better health outcomes and satisfied members. Then in order to achieve it, we can look at the WHO model on building the health system or health system strengthening. And the fourth item on the slide lists access to essential medicine. It's abbreviation or short for what's in the literature of access to essential services, essential medicines, and essential vaccines. So that in a nutshell tells us how we should be structuring the content of the medical scheme if we want to see improved health and responsiveness in the system. That's the critical one that we need to work towards. So literally, we need to ask ourselves, do we design benefits that are money bags? And as long as you've got benefits in each of these money bags kind of thing, well and good. If that money bag gets empty during the course of the year, well, tough luck. Then you have to pay out of pocket or love and fresh air. However, we need to design it in a way such where it lists all type of essential services. To some extent, we do have examples of it at the moment. For example, in optometry, we list benefit as consultation benefits, frame benefit, optical lens benefit type of thing. That's the way we need to be designing all our benefits. We have a crude form of it in dentistry where we talk of conservative dentistry and specialized dentistry. What we don't have in our environment is something that looks like this. On the right-hand side is a kind of a detailed list of services that is included in what we mean by service-based benefit package or conservative dentistry. BHF's document is listed there on the right-hand side that was published in February 2007, which takes this concept a little bit further of the common benefit and actually specifies a lot more of these services that are to be included. In that specified list, you'll notice all the services not just included, but on the right-hand side of it, some of the limitations, because we can't really make everything available for everyone else. There's potentially opportunity for a lot of abuse. So you then limit it to some extent, 2 consults in a year or 1 X-ray at a time or 3 X-rays at a time, etc. This is the kind of benefit details that we need to develop. For medicines, as was mentioned earlier, we need to embrace essential medicine list right up to quaternary level of care. I know in the low-cost benefit option, we've recommended to be at least at the primary care level. I think the final piece of the puzzle is this thing of price certainty. Okay. And I talked about this thing that healthcare, like electricity, is not a commodity, and therefore its price need to be prescribed. And maybe electricity in Eskom is a bad example with the way it's dysfunctional at this moment in the load shedding that we have. The worst of all is the 32% increase that they're requesting. I don't think we'd like to see that in the healthcare service pricing environment, but price certainty is absolutely important. You cannot prescribe a benefit and not necessarily prescribe a price at which those benefits are procured. And I think that is absolutely important, and it's unfortunate that the Department of Health or the Council for Medical Schemes haven't taken their steps further to try to bring the certainty in the environment. So absolutely critical is equitable health access is within our reach. We just have to make the decision and get it implemented. And I'll say thank you very much.
Thank you very much, Dr. Raja. Yes, you are a gem. It's okay, you can own it. So we have a few more topics that are left before we start with the Q&A. I am receiving your questions, and thank you for putting them up. So we will get to that, and we'll make sure your questions are answered. But right now, to talk about the patient-centric strategy that is needed for value-based care, please help me welcome on stage the chairman of IPA Foundation of South Africa, Professor Morgan Chet.
Thank you very much. I must thank James for inviting me to share some of my thoughts on patient centricity. I also must congratulate James for having decided to discuss this particular topic, because I think you guys are used to innovations, and I think this is an innovative topic because it's been neglected and I think very underfunded in this particular country. So I'm in a very disadvantaged state because all the speakers have covered my topics. So Program Director, can I take question and answers? So I'm going to try and go. I won't talk to my slides. I'm going to talk around my slides because some of the topics on my slides have been covered already. Can we move on then? Oh. Let me go back one more. Giving a little bit of problem. Okay. Actually, the first slide is missing. I would have wanted you to see that because in the first slide, what I've done is I've discussed patient-centered care, and I said the future is not patient-centered care, it's person-centered care. And the reason why I'm saying that is we shouldn't be waiting for people to become patients. The future is preventing them from becoming patients. So Margaret Chan said before she left the WHO, can we correct that? And she said it was incorrect. And the correct way to talk to them was about person-centered. The second important point is we've moved away from the dialogue that asking the patient, what is the matter with you? Now think about that question. What is the matter with you? Actually is a very closed question. It doesn't allow the patient the luxury of the narrative to engage in a conversation. So the new way we talk about this is what matters to you. When we talk about what matters to you, we open up the narrative, allowing the patient to discuss the issues. So I'm going to look at this and tell you, in the world of consumerism in healthcare, and as this continues to grow, providers must organize themselves around the patient's needs to deliver greater value in order to earn and protect market share. So we need to redefine, and I've just been through that with you, around what matters to the patient. There are two overlapping strategies or philosophies or converging philosophies, and these are patient-centered care and value-based care. You can't talk about one without the other because patient centricity, which has been neglected, is an important part of us discussing and measuring value. So I think that's an important issue that we need to look at, the interaction between the two. And patient-centric care involves a number of different dimensions. And these dimensions have been discussed by numerous speakers. So I'm not going to go through that with you, but the slides are available for us to discuss. So let's discuss this idea of co-creation. This focuses on the customer participating or create. Now, healthcare is a service. And if you want to discuss a service, you got to co-create that definition. And by co-creation means the participants that are going to share in that service should be part of developing that service. So I think co-creation embodies a different idea altogether. We've been very paternalistic. We've been very undemocratic, and we sat in closed rooms and closed doors discussing what we think the people out there should be receiving. Co-creation is not that, it's the contrary. It emphasizes the customer participation and the interaction with the supplier of services. So suddenly we find that we're now talking to each other and we're not talking down to each other, which is what patient centricity is all about. McCall Kennedy, in some work that they did, defined this very adequately when he said, patients are value creation as the benefit that patients and medical service providers create through interaction and resource integration. And the two types of resources we're integrating here. One is operational resources, and the second is objective resources. So there's a question being asked by a patient or lady, and you can read that and you can put in your own answer there. With the development of science and technology, and I'm not talking about Dr. Google, I'm talking about internet when used appropriately, we have decreased the asymmetry of information between the patient and the doctor. Nowadays, patients come to the doctor and tell the doctor, doctor, this is what I think I have. So they've already equipped, and the HMI inquiry actually brought up that point in particular, that the asymmetry of information was the reason why healthcare costs were so high and quality wasn't accounted for. Patients can now, with the information they have and the information that they gain from a discussion with the doctor, they can discuss and even question the disease treatment plans that the doctor, instead of being accepting passive. So what we've seen here is, with this new system of talking and educating patients, we're moving patients from becoming passive recipients of instructions to becoming active participants in care. That's the big word. They're now actively participating in their own healthcare rather than sitting. We come from a legacy of paternalism in which the doctor was right and the doctor dictated from top. We're moving away from that. So value co-creation is of great significance for realigning value-based care and improving the doctor-patient relationship. So what is co-creation? Co-creation is a function of an interaction that takes place and ultimately drives value for both the provider and the recipient of care. So let's look at some of the benefits very quickly. By talking together, knowing what the patient wants, what the patient is expecting from the health system, we can get a better product on customer desires. Not what we think they desire, but what we can from the narrative. We get a better financial performance. We get new and unexpected ideas that we never explored because we never asked. Making the customer part of the creation process, you get a better buy-in because they co-created it, so they will understand why they co-created it, and they will get a better buy-in. We can remove barriers. This is the big thing of the future. We have an empowered patient. The patient is engaged, and the patient is informed. This patient can now make informed decision-making because he's equipped with the information that helps him to do this. Prior to this, this wasn't the case. And we have an increase in health literacy, and we have better adherent behavior. We'd like to use the word adherent and I was going to say the word, but I'll stop it now. Adherent, because we think if you say compliant all the time, it's still too top down. We like the patient to be adherent because it's a joint decision between the patient and the provider of services. Now, I want to take you to this. If it's one thing I leave with you today, patient centricity is not just about the patient. The patient plays a role, but an important role has to be played by the healthcare provider, the doctor. And I don't think the doctors, sorry if there's doctors in the audience, I don't think the doctors are doing enough to assist the patients understand the issues. So let me tell you what happens. A patient enters your rooms. Allow the patient to lead the narrative. Don't interrupt the patient if you're a doctor, because you don't allow the patient to say the full story. Engage the patient in active listening. Look at your patient in the eye and talk to the patient. Don't let the patient talk while you're fiddling with your cell phone or you're fiddling with your computer. That's not active listening. You must engage this patient. The patient must feel that you're part of his pain. He's part of his suffering. Then the patient will trust you. In doing this, you develop a thing called a therapeutic alliance. You develop alliance with the patient that helps you to manage the patient, because now the patient, you understand the patient sees that you care for him, and you find that it's a better kind of relationship that develops. This is now a very engaged patient, and they're engaged in their own healthcare. They're not sitting in the periphery. They're not numbers anymore. We're so used to saying, you've heard it in the past, we're now seeing patient number 34. The patient is no more number 34. The patient has a name, and the patient must be part of this process as an individual who's able to decide for himself. We also use a thing called motivational interviewing. And I'm saying to you that this is how we make patient-centered care happen. Motivation, you sit with the patient, you can motivate this patient, and it's by educating the patient. And we've come up with a new theory, it's called know your numbers. Now, know your numbers is very, very important. We tell the patient what a hemoglobin A1C is, it's for diabetes, but tell him why you're doing it, what you want to learn from it, and why the number 7 is very important. His hemoglobin A1C must be under 7. His BMI must be under 25. So when the patient gets this information, he goes to his doctor and says, doctor, I want to talk to you about my blood sugar. Why is it 8.5 or 10? Am I getting the right treatment? Are you giving me the right medicines, or am I doing something wrong? By knowing your number, you allow the patient to engage in the conversation with authority, right? So you don't give him 25 numbers, please. Just give him 5 numbers for the 5 top conditions, and he can talk. His sugar must be under 5 at a certain time of the day. His blood cholesterol must be under 5. His blood pressure must be under 130/90, something to that effect. So we got a new strategy saying, know your number, and this allows the patient to engage with you. This is some of the types of co-creations. You can collaborate with the patient. You can help co-design what's already there, or you can do some tinkering of the product, or you can do new submissions. So these are the types of things you need to do with the patient, and the patient must know why you're doing this. When we have a very big mass of people, just remember something, that sometimes the mass is not wise. They're very emotional, so you need to use evidence-based information that the patient will understand. I'm not going to go to the summary. The summary is what you've been through, but just the last line. When patients co-create healthcare value with the physician, they participate in a whole process of treatment because they've been part of the development. So value-based care from a patient's perspective has got 3 arms to it. You get better health, better care, and lower cost. Now, in the past, and I'm sorry I have to say it here today, funders concentrated on the cost, and we didn't concentrate on the other parameters. I think now it's important, if you look after the patient's health, give him good value, better care, cost will look after itself. So I'm going to look quickly here, and I'm not going to go through all these slides because I've just been through that with you. Just to say one thing, that it's not a one size fits all, because when you decide the word value, the value will vary based on the type and situation that you're in, and the kind of healthcare discipline you're in, and the kind of health problems the patient has. So if we look at the value, it's got a number of components. You can read that. It's got the clinical component that Barry Childs measures for us and we use. We have non-clinical components that you heard earlier on of the patient experience, because how do you find out, is this patient free of pain? How do you find out this patient got back to activity? Is he mobile, right? Is he more productive? You can't get that from data that you get from claims data. You got to talk to the patient. And that's why we have what we call PROMs and PREMs, which are patient-reported outcome measurements and patient-reported experience measurements. These are the new ways that we can use to complement the information that we get from data. And then we've got to look at what's the effect of costs and out of payment to the patient. A lot of patients see this negatively and they forget the positive aspects of their healthcare. So you're going to look at this because this has an influence on this. So while value definition may be a procurer specific and subjective, value can be defined as desired outcomes related to costs. So I'm going to look at this little I'm just trying to read it because I can't read the top part there. Okay. This is important because it summarizes everything we said for today. We are at a point where economics are nearing a limit of what we can afford to spend on healthcare. Demand is increasing as new treatment modalities and molecules are available in the market. Consequently, the focus on the provider and the payer is shifting to enable them to get better value for money spent, a concept of value-based healthcare. Value focuses on spending well, as well as spending less in the medium and long term, not just costs, but the benefits to the broader patient health and ecosystem. Value-based care is certainly not based on care at the lowest cost. I think that's the most important part of this slide. It's not just looking at the lowest cost, but the best value or the best quality the patient can get for the costs that we can afford. To achieve this, we need to be informed patient, an empowered patient, a patient who understands their healthcare seeking behavior, who understands how he participates in it and understands the value he gets out of this, rather than just being a passive recipient of care. When we teach the patients and the patient understands and is engaged and is informed, this patient can make what we call informed decision about himself and his healthcare. So he becomes the new co-creator with his healthcare provider in terms of the delivery of healthcare services. I'm going to end with this, with the slogan, Chair. And the slogan is that from a patient's perspective, nothing about us without us. We need to be part of the process. Thank you very much.
Thank you, Professor Chetty. Nothing about us without us. It's so interesting learning about this and who's more empowered, who's more engaged, who's more informed. I think all of us are that patient, which is why it's important for medical schemes to sort of evolve with this new patient. And I think so do health practitioners. You know, Professor Chetty was reminding me when he spoke about the experience we have as patients, of my experience with an ophthalmologist a couple of years ago, who told me that I needed to do a cataract surgery. I was like, why do I need to do that? And he wasn't engaged with me. He was giggling on his phone while I was trying to digest the magnitude of what he just told me. I didn't even know much about the cataract surgery and how big a deal it is. But while I was digesting that, he was on his phone and he was sent something very funny and he was giggling about it. And that, the long story short, I never went back to that doctor. So thank you for reminding us of that, Professor. And you were right, a lot of the topics have been covered this morning. Most of them have been covered, but there's just one more. Redesigning healthcare for the needs of the health citizens. And Kelly Duplessis is going to present this last session on this. She is from Rare Diseases South Africa, and she will tackle this topic from a patient perspective, and she joins us online. So Kelly, over to you.
Thank you very, very much for having me this morning. Well, Dr. Chetty, if you thought it was going to be tough for you to do your talk, I think the last succinct points that I had to add have certainly already been spoken about. So I feel that I'm actually going to
Kelly,
go
I
over
think
some
you
of the
may
notes.
be. There we go. Thank you. You can go ahead.
All right. Thank you very, very much. What I was saying is that Dr. Chetty had adequately pointed out that so many things have already been discovered and has made it even more difficult because he has highlighted my last final few nails in the coffin for today. So I'm actually going to now work a little bit on the fly, and I'm going to review some of the notes in terms of that I've taken in the course of today. Just for a little bit of context for those who don't know who we are a patient advocacy group, and it's really, really encouraging for us to be invited to come and engage on this really, really important topic of patient centricity. Because if I can be brutally honest, I think we hear about it a lot. There is certainly a notion that that is what is wanted. However, we don't seem to see it turning into practice. And it has been really encouraging for me this morning to hear from so many of the GEMS team on what they are doing in terms of achieving patient centricity. So I'm certainly super excited for the future. And like one of the previous speakers said, I'm hopeful that possibly I will be able to become a GEMS member at some point, because it certainly seems like a good medical scheme to be on. So I think one of the first things that needs to be made very, very clear from a patient perspective is with regards to the fact that patients are now coming into the fold as informed individuals. We are no longer coming to doctors for their opinion. We're coming to them for ratification of what we've read on Google. Whether or not we agree that that's the way it should be or not, that is essentially how it's happening. And the same goes when it comes to understanding your medical scheme benefits and the themes around that. Because essentially, because of social media, because of the fact that we are such a communicative generation now, you understand very, very quickly what schemes are doing and what they aren't doing, based purely on other people's experiences. So it is, we come into the bargaining discussion around value with a very, very different notion of what we did a few years ago. And that has been both a good thing and a bad thing. It's been a good thing in the sense that patients are obviously now more informed, and we have a much better ability in terms of discussing things of value. It's been a negative in the sense that I think that there has been a fair amount of, I want to say almost risky decision-making from patients or from members who haven't necessarily been completely informed. And that's something that we need to obviously work in countering and using information correctly to address. So some of the things from a patient perspective that we often see that really matters to patients when it comes to engaging with their schemes, and when it comes to this notion of purchasing value healthcare. The one is in terms of benefits. Patients want to be able to know, and I refer to patients, and it should be members, sorry, it's just because we refer to them obviously as our patient cohorts. So members want to be able to understand their benefits. You want a very, very clear-cut indication of what you're purchasing. If you go into Pick and Pay clothing and you're looking for a t-shirt, there's a range of t-shirts. You can see exactly what the price is, what the size is, what it's made out of, what its washing requirements are, etc. You know what you're getting. I feel very often when it comes to the medical schemes environment, you kind of get this, you're getting dentistry, and I'm going to use dentistry as an example. So great, I've got a benefit of 7,500 Rand a year for dentistry. That's fantastic. I've tripped, fallen, knocked out my tooth. I'm now going to go to the dentist to have that tooth replaced. And then when you try and apply it for approval, you get told, no, we only will replace the tooth that we've removed. We don't replace the tooth that's been removed on its own. So then you're like, but why? Because I've saved you the time of removing the tooth, but in actual fact, you need the tooth to be removed for there to be a quantifiable code to be able to build on the replacement of the tooth. Or you will decide that you want to go for your oral hygiene appointment to discover that they'll only cover half your teeth being cleaned this year, and the other half will have to be done next year. So patients really, really want that clear, concise benefit. And I think what Dr. Patel had put up when he was highlighting the essential services really, really breaks it down. It's a line item. We want to be able to see, you know, these are the amount of appointments that you get. This is where you can get it. This is what the limit is on that particular benefit, so that we know what we need to do in terms of managing those expenses through the year. Then when it comes to policies, as members, we join a medical scheme as a grudge purchase, knowing it's something that you have to do, particularly in the context of today, you know, the state of healthcare in South Africa. So it's a grudge purchase. You purchase this thing. And then whenever you're trying to get information about it, it becomes increasingly difficult. So access to information is critical. Your policies and procedures that you refer to when providing authorizations or providing feedback to members, they need to be clear. They need to be written in a language that is understandable to lay people. It doesn't help to reference things like prescribed minimum benefits and regulatory policies and formularies, etc., because those don't make sense to us. What we want to know is, here is a list of conditions, and this is what we cover for the list of conditions. Or this is the policy, this is essentially where you can find it. So often, and even us as a patient advocacy group, when emailing and engaging with medical schemes, we have to request their policies and their exclusions be sent through to us. And even that can sometimes take a week. So that these things are not easily available to find, and they are also written in a language that is completely incomprehensible to the average layperson who has no understanding of what it is that they've purchased. When it comes to treating people, it's important to understand that that is what we are treating. These are people. They need to be treated holistically. They need to be acknowledged as holistic beings. So things like the multidisciplinary care approach, those should be encouraged. We've had situations where you have a patient who has a really, really high adipose tissue and they're overweight, that are being treated on a weight-based product that is exceptionally expensive. So as opposed to offering them something like the lines of biokineticus and dietary support to bring their weight into the relevant range, so that not only is the patient healthier, but we are treating them with this particular drug more responsibly, we have a situation where those benefits are not approved because no one's thought to put them in. And essentially we're spending sometimes hundreds of thousands of rands treating adipose tissue that actually doesn't benefit from the product. So, you know, sometimes thinking a little bit out the box, taking a step back, looking at the patient as an entire being, and really then analyzing what is the best approach for that patient really, really does make a difference. I think it's also important to understand compliance. People who are informed and patients who have felt that they are involved in the process, exactly what Dr. Chetty was just saying, are generally more compliant patients. Patients who feel that they've been forced down a road or who have been requested to do something that they didn't quite buy into in the beginning are generally the patients that are non-compliant, and these patients have reduced healthcare outcomes. And ultimately, at the end of the day, it's an unnecessary waste in expenditure. So if my doctor has prescribed me product A, and I've now gone to the pharmacy and been given product B, and no one has explained that product A and product B are essentially the same drug, I'm of the view that my medical scheme has now just told me I have to take this other product that I didn't want to take from the beginning. And as a result, I don't. And there we paid for the product. It's come out of a service, it's come out of a benefit, but it is actually not going to address the patient's needs at the end of the day because the patient hasn't bought into the process. So compliance is so critical, and encouraging patient compliance and doing everything possible to ensure that patients have the necessary means and mechanisms to understand the decision-making that is placed in front of them is so important. When it comes to things like referral pathways, understanding designated service providers, patients, again, in your mind, you've developed you've asked on social media, this is generally how it goes. You've got a sore foot, you've asked on social media if anybody knows a great foot surgeon, because in your mind, that's what you need. And you get a whole bunch of references for a particular surgeon. And when yet your scheme's saying, hang on, you need to go to the GP first. And you can't understand why it is that you need to go to that GP. And if we can just clear up the communication on, we are asking you to first go to the GP, because sometimes these are things that don't actually require surgical intervention. And you're given a choice in terms of a GP that you are comfortable with. You're not forced to go to a particular doctor who you've never heard of. You might actually resolve the issue without the unnecessary expense. Generally, patients don't engage in that process. They will go and pay out of pocket for an appointment that is often not necessary at a surgeon who might be, not included as a DSP, etc. And ultimately, we've just driven up the costs exponentially of treating what might be gout. So patients really need to understand that referral pathway better, and there needs to be things that are implemented to be able to assist them in understanding that. Then when it comes to understanding value, and I think Dr. Chetty really put it well, but value for patients doesn't come down to just economic cost. It comes down to the cost of spending time with your family, the cost of being in pain, the cost of missing work, the economic impact in your house of being a mother that is now the primary caregiver to a patient, and the costs are much larger than just looking at the economic scale. So sometimes when evaluating a particular patient's case and looking towards, what would be the most holistic thing for this particular patient, those things need to be taken into account. I'm going to give an example. We've recently had a patient, a doctor submitted a patient to us for assistance, and that patient requires continuous immunoglobulin therapy for a primary immune deficiency. This patient is now in high school. They're in boarding school, and that boarding school is approximately 300 kilometers from home. The scheme has only approved an IV version of the treatment that's required because that's what's listed on their formulary. But that entails that the only time that the patient ever comes home on a weekend, that patient is then admitted into hospital for the weekend to be able to get that IV, as opposed to offering the patient a subcutaneous product at marginally the same cost, but the overall cost to the patient and the compliance of the patient and the overall response to treatment is so much better when you've taken that patient's personal considerations into account. So it's definitely not a one-size-fits-all approach. And unfortunately, obviously, these are difficult things and require a lot of human resources to get to the understanding and the nitty-gritty of these things. But we have seen where schemes have employed the use of case managers for chronic illness. It really has made a big difference in terms of patients getting a better understanding of the scheme's perception of things. And it has improved that rapport in terms of everybody feeling like they've had an opportunity to have their say from a clinician's perspective, the patient's perspective, the scheme's perspective, and then everyone's kind of reached a consensus on the way forward. So where possible, particularly in the long-term life-limiting, long-term chronic conditions, certainly a really good value-based proposition that can be put in place is to offer case management services where you are not calling into a call center and having to re-explain your story every time you phone, but you are able to speak to one person who has an intimate knowledge and understanding of what it is that you're going through. And then also just, understanding in terms of things like PMBs and understanding patient benefits and, processes and disputes. Generally speaking, patients, we've got two situations. You've got one where a patient is actually none the wiser of the fact that they might have a PMB condition. And this was also referenced earlier, and Dr. Malobi said it earlier, when he referred to the fact that he'd had a family member who had gone for something that was actually a PMB. You don't know what you don't know. So as a patient who's never experienced a PMB process, or who's never been diagnosed with this condition up until that particular time, will be none the wiser that their condition is essentially a PMB. And as a result of that, very often, the claims process gets skewed and gets completely ruined simply because of the fact that the patient doesn't actually know the question that they need to ask the scheme, or they don't know the process that needs to be followed because it's foreign to them. when it comes to disputing and reviewing these sorts of things, it also becomes, it doesn't need to be considered as an adverse process. It needs to be understood that there is a difference in opinion, and it needs to be seen to be a consultation to be able to resolve where the difference in opinion is, and for that to be adjudicated in a way that everybody can understand the decision going forward. And I think that that for patients is such an overwhelming, frustrating process. And I honestly feel that, you know, particularly we've got a reputation, it's particularly of late in terms of our Council for Medical Schemes and the complaints that we lodge there. But I think very, very often with open, robust communication between the scheme and the patient and the healthcare professional, a lot of these issues can be resolved, and we're just missing each other, you know, from a communications perspective. If you open those lines of dialogue and you make the flow of communication easier, it makes it that much easier for patients to get some form of a resolution, and then often those cases are resolved. And when it might even be that you've now managed to get the patient to understand why the care that's been put in front of them has been offered in comparison to what's been requested. So really, these are interesting, quick little tools and tips that we feel that could really be utilized in terms of trying to develop this patient-centered model. It is largely administrative, and we understand that. I feel all the stuff that could have been given today in terms of benefit design has already been discussed. But I feel like it is important to understand the administrative burden that often comes with these lifelong chronic conditions, and the long-term challenges that result, and the breakdown in communication between schemes. And then I just wanted to also make mention with regards to PMBs, and I think it's just so important. If you have to ask patients, and we see a lot of the positive and the negative narratives that circulate, if they had to put it into a sentence, what it is that they want the most, it's patient certainty. It's an understanding that this is my benefit, and this is how it's going to be utilized, and this is how I can get it. Patients don't necessarily understand this concept of we're going to refer it back to a state level of care, because the first thing they say to themselves is, if I wanted to be treated the same way I would be treated at a state facility, why am I paying the premiums I'm paying every single month? So to go back to them and give them the feedback, it's not state level of care, just frustrates the process even further. When it comes to PMBs, it would be a fantastic start if we could really put together a comprehensive list of essentially what is covered under those PMBs that is equitable across your scheme. And by doing that, it would be a really, really good pilot study for us in terms of breaking down these line items that are required in understanding your benefit design, because the PMBs are set and they should be certain. And we've seen recently with our recent High Court ruling, where we've had to actually approach a court to be able to provide us with an interim relief so that we had the time necessary that was required to take the Council for Medical Schemes process, because that process is very, very often cumbersome. It can take in excess of 3 years to actually get it resolved. And in the time that these patients wait, the patients are essentially without treatment. So if we can start drafting really, really clear, concise, basic benefits that are explained easily to patients, or the information is easily available to patients, I really do think it would be a great, great start in us moving towards this patient-centered approach, where patients are clearly of the opinion that their schemes understand value, understand what's important to them, and that they are valuable members in the decision-making process. So I thank you so much for all your time today, and we look forward to the great debate later.
Thank you very much, Kelly. So from one member perspective to another, please help me welcome Basil Manuel, who is the Executive Director at NEPTOSA. Mr. Manuel, over to you.
Thank you, Clement. Good afternoon, ladies and gentlemen. I, like so many others at the end, Kelly in particular, of course, has to deal with the fact that so many people have been speaking ahead of us, and of course have covered so many things that we would have liked to cover. But nevertheless, you know, whenever I join one of these meetings online, it always sounds like and seems like I'm in a seance of some sort. Have you heard me? Do I feel your presence? And so on. But I'm not going to go there. Ladies and gentlemen, I certainly heard the definitions of a patient-centric approach. But what I didn't hear is what GEMS's definition is. I've heard the textbook definitions. And it's important that we begin to see what of those definitions exactly apply to us. Because when it comes to the member, we would like to know where this goes, how this goes, and when it will reach the bottom. Professor Chetty spoke about, he quoted something which we quote a little differently. We always say nothing for us without us in the union environment, because we want to know, when does this filter down? Because at the end of the day, this is about us. And that is where I would like to see this ending, this little input. Now, when I talk about the definitions, I'm saying, how far do we envisage it going? How far do we see this respectful, responsive care to patients' needs going? Do we see it going as far as assisting patients to leave this mortal coil, as Hamlet said? Or do we see it as something completely different? Now, we can speak about all the niceties, and I want to say this is an extremely important topic, and it's potentially revolutionary because it changes a whole system. And of course, it's courageous as well, because it does change power relationships. And if you look at it for a second, up to now, and still today, the people in the medical profession have been seen as a form of an oracle. They knew all the answers, and the patient simply just had to accept, and still does by and large. And then, of course, we saw the social impact of COVID-19. And suddenly, a whole host of people were being influenced by things other than science sometimes, but they started having opinions. And those opinions were being expressed in all manner of way, but more importantly, it countered what a lot of the important, well-educated and well-meaning medical people were trying to do. And this is the danger of social media, but the bigger danger is the disempowered, the unengaged, and the misinformed that then start making decisions based on everything being said out there. And when we talk about the member perspective, as the unions, we are constantly saying, talk with us, not to us. Don't tell us, engage us, because that is where we want to be. What we have seen in recent years, the trends in terms of members of GEMS, talking to the unions, and remember, we in the public service unions, and GEMS members are only in the public service. So we represent all the members that GEMS has. And we have seen how the users of GEMS have become more critical. And a lot of that is not directed to GEMS, it comes to the unions, because in the Public Service Coordinating Bargaining Council, hello Frikkie, we then sit with all these issues and we table them with GEMS. So engaging the member becomes important. So when this does filter down from the medical aides to the doctors, to the nurses, and all the people within the medical profession, then and then only does the real issue happen, where we will see how patient-centric the approach really is. At this level, it is still very much a theory, but our members want to be considered. They want to know that their views are also matter. And when it comes to dissatisfaction with individuals, the very social impact of COVID comes back to play. Somebody mentioned it before. People go onto social media. People start looking at Google Doc and all these type of things because they have become more empowered today in terms of social media than ever before. Now, unless we engage our members, unless you engage our members, they go and pick up things that are not exactly in keeping with what the medical fraternity would want them to know. But somebody out there has this theory, and we've seen how it played out there. Now, ladies and gentlemen, the bottom line for a union is that it has to do with greater and better communication. I want to congratulate GEMS for upping its game tremendously over the last couple of years. However, to have a few liaison officers in provinces or in cities, etc., is definitely not enough. When we start talking about how people want to be listened to, and I think it is Professor Chetty who spoke so very nicely about people being distracted, and Clement also having a view on a distracted service provider. And that is exactly what I'm talking about when I say we want to be communicated with. We want to be part of this because our members certainly want to see that the views they have are being listened to. The patient's feeling is being considered. Now, it expresses itself in various ways. Unfortunately, most often, members look at issues of cost before they look at the quality that is within a scheme. And every year we deal with this when it comes to talking to GEMS and other medical aids as well. But the relationship that GEMS is going to create through itself with doctors to promote this is, I want to say, one of the most revolutionary things that we will have in a long time, one of the most courageous things. But it cannot only be here where the talking happens, because we must empower people. Now, people in the union and people in the public service are arguably at a better level than what many other people are out there. And when do we have, when do we get to those many people who are utilizing services that they're not always happy with? And we have doctors providing a service that they don't seem to think is all that important to the patient. And all that can happen is that the patient has to accept what they get because they don't have any other choices. From a member perspective, I want to say, this is where we want to go. Let us make it happen. And the sooner we do so, the better. And once again, nothing for us without us. I thank you.
Thank you very much, Mr. Manuel. That's what I like about unions. They tell it like it is. Eh? You want to talk about patient centricity, you must walk the talk. And if you don't, they call you out. So if we want to go towards this patient-centric approach, it's not just going to take GEMS, it's not just going to take the other stakeholders, but it's going to take government as well, because as you've heard from many of the speakers, there's a lot to do from a policy perspective, from a regulation perspective. So please help me welcome the Director General at the Department, the Deputy Director General at the Department of Public Service and Administration, Dumisani Shope.
I accepted the promotion. It's not my mistake, it's your mistake. And I'm happy to benefit from it. Colleagues, good afternoon and all protocol observed. I think I am here on a learning journey. I'm introduced to this topic. And as somebody who was responsible to develop research, it's a very, very good opportunity for me to be here. And I am very grateful for that. And I think I must thank Professor Chetty, because he has already done what I was about to talk about. The question is, how do you turn what is said into a policy perspective? I think that's what we are dealing with. But just to make a few comments, colleague, I think we are moving from a perspective that says we are leading and managing a modern government. And the features of a modern government is that it is knowledge-driven and it is highly technical. But government in itself does not have the capacity to undertake all these issues that are knowledge-driven. So it's always a great opportunity to receive these kinds of initiative because it begins to position us as government to say, what is this issue that we need to pursue? But next to that is also the understanding that we are running a very multidisciplinary institution. And we are expected to navigate across these disciplines that we have put on the table today. So this is a very good initiative. We appreciate it because it gives us a sense of a perspective in terms of what policies do we need to develop to make sure that we realize what in earlier days it was called the Batupili, but I think the agenda of a patient-centered policy orientation, it begins to give us a more specific orientation in terms of what needs to be done. We are also mindful of the fact that part of the importance of a patient-centered approach, is the fact that the modern citizen is very conscious of one's rights. The modern citizen is very conscious of what needs to happen to realize his or her own rights. I'm not sure if the modern citizen is equally as active when it comes to one's responsibility. But we are dealing with a highly informed citizen to this day. So it makes sense to engage them at all times in everything that we do as government. I usually say to politicians that this is the worst era to be a leader, to be a political leader, because you are not leading the naive. You are leading, people that are, they are very informed. So here are some of the points that I think I should like to put on the table. I think so we need to create a policy, an enabling environment. We need to create a framework. We need to create measurements that will make sure that we do move in the direction of a person, Professor Chet, is a person-centered care rather than a patient here. Because I like that because it begins to build up the value of an individual rather than being seen as a patient. So how do we see it? From where I'm standing, we have to pursue a policy program we have to develop a policy in this regard. So the first thing that we need to understand as we develop the policy in this regard is the fact that this patient-centered care is actually about the healing rather than the traditional treatment or cure at a conceptual level. Once you begin to engage a person on the health status of that person over time, I think you are more in the process of healing rather than simply a cure or treatment. And the healing will include issues of physical, psychological, emotional, and all of those other issues. So as we begin this process as the DPSA, working with GEMS to work on a possible policy framework in this regard, that is the point that we are moving from. That is how we want to understand this issue. But I also have one question that I think we must deal with on a policy level. The relationship between the doctors and the patient, because one of them is an expert. The other one is not an expert, but is a central figure in the process of being healed. So what type of engagement do you have when one is powerful based on the knowledge and the technicalities that that person possesses, and the other one needs healing. So we need to contextualize that, because as much as we want to create a sense of equality of one sort or another, one is a patient and the other one is a doctor. So how do we deal with that type of a relationship? But also second to that, how do we deal with Dr. Google, so to speak? I heard as part of the speeches today that it's possible that people will go to a doctor and say, this is what I think I'm suffering from. But the other person that studied for this. So these are the contradictions that as we develop the policy, we should be able to deal with. So there could be three elements that we need to deal with from a policy perspective. One is, what is it? We must clearly define what is this patient-centric care. So we must define it in absolutely clear terms what it is. So the policy should contain that. The second part is the how part of it. How do we drive this policy framework? How do we create mechanism for those that are involved to operate within that sprint? And the third one, as it's good with each and every policy, how are we going to undertake the measurement? How do you measure a sense of saying that, this regime that we are trying to build within the health sector, it is actually happening? So, so there are three factors here that we are looking at in terms of entrenching a possible policy of nature. Number one is the critical involvement by the patient. So the policy that it is likely to come up with, it must reflect that. How do you engage the patient? This could be at an individual level, but it can also be at a collective level. It could take organization, it could take community individuals that are going through similar kind of health challenges. So point number one, after we define this thing, is how do we get people involved in that health agenda? The second thing that I think our policy framework should begin to look into is how receptive are the professionals in the field, how receptive are they to this agenda that we're putting on the table, or the different way of doing things? Are we having too many of conservative medical professionals, or we do have people that are willing to change? And if that's the case, what kind of training needs to happen? Because in most cases, it's very possible to be good at something, but a very poor communicator in that regard. When I did my master's degree, I did well by reading the books written by my supervisor, but not listening to him. He could write well, but he was not able to communicate well the message that he needed to do. So the responsiveness by the sector, I think, is very important. And then thirdly, what type of a supporting healthcare environment or infrastructure should government put into place to make sure that this health policy regime, it happens in a proper way? So for me, the point of departure as government, we just have to learn what is the meaning of a patient care-centered approach to health provision. Because for now, I'm not sure if we are very informed or slightly informed. We have been relying on what we call Batupili principles, but this one is very specific. It's detailed. It's what you could call occupational specific dispensation, which government is actually reviewing to check if it's working or not working, or if the money which is paid to medical professional, is there any value to the state or to the patient in that regard? So it's a learning curve for us. But in conclusion, yesterday we launched what was called a professionalization of the public service, which I think this is where it falls, you know, this agenda falls in. The professionalization of the public service, the framework for the professionalization. And there are two elements here that we need to deal with. One is the meaning of this professionalization. For some people, they think it's a qualification. Qualification is just part of it. You can be qualified in a particular field, but not necessarily a professional in that area. So professionalization in this regard, it takes two elements, both the qualification, but also the attitude and behaviors in executing your professionalism in the area within which you are operating. And this sector, for me, the health sector, is one of those that require very, very strong element of professionalization, particularly because one single mistake, someone can lose one of his life. In fact, I think most of government departments of the work that we do, we can take a clue from the medical sector, because you have to be precise, you have to be professional, both in terms of your qualification, but also in terms of your mannerism and the behavior of executing that within which you are a professional from. So, Clement, you'll be interested on this one, which is part of our professionalization. So most of you will remember, no, you may not remember, but I assume you remember. 10 years ago, government adopted the National Development Plan. 10 years after now, there are narratives around a failing state or failed state. And it's not all of us, whether in the health sector, whether in the infrastructure, these are issues that we must preoccupy ourselves with. And in November, there's a conference that we are going to review the state capacity since the adoption of the NDP. Have we gone north or south? So if I think some of you here can do some very nice presentation there that presents the state of the health sector in terms of the capacity of the state to deliver appropriate services. The outcome of that conference, it will be to have a strategy on how to build and sustain the capacity of the state. Finally, I think for me, I am a great fan of productivity issues, especially productivity in the public sector. Many people think productivity is simply related to the private sector because it's profit-driven. If you are talking about productivity at Coca-Cola, it's clear. You have to produce Coca-Cola cans, you must sell them at profit. But if we are professional in the public healthcare system, we should develop our own productivity measurements. The policy must indicate that. And some of these things, they are not very difficult to figure out. Because if I go to a clinic and I spend an hour without being seen by a doctor, that clinic is not productive. Or if I go to a clinic and I can't get Panado to deal with my babalas, then it's not productive. So as part of this policy orientation that James is nicely putting on the table, we need to take it forward in that regard. So it's something that we are looking at from the DPSA, but we have, aside from reviewing the existing literature at this point in time, we haven't gone beyond that. And we will be very glad if you, as the JAMS be the responsible agency, and we we push it together from our side. There is also the NHI, which could be activated anytime soon. It also needs some policy reflection in terms of the impact that it will have, both within the state apparatus and the citizenry at large. And thank you very much for hijacking me to address this very difficult subject. Thank you.
Thank you very much, Mr. Shope, the Deputy General. I promoted you there, but I must tell you, I went on my show on the day Liz Truss was appointed the Prime Minister of the UK, and I said, I give her just over a month. And I took a bet with one of my listeners. His name is John. And we bet, the bet was 1,000 Rand. And I'm 1,000 Rand rich today because I called it. And that's not the only one. I also took a bet last week, Friday, and I told my listeners that the best team in the country is going to beat Sundowns. And what happened? Exactly. So what I'm saying to you, Mr. Shope, is maybe this is a prophecy. Do that with what you will. Okay, so we're going to get to the questions now shortly. But before we do, I just want to make this announcement. We're going to ask that if you are here in person, you can go get your gifts and collect them at the GEMS team desk just outside at the end of the symposium. And also can we please ask all the speakers, GEMS board members and ESCO members to just stay behind so that we can take some pictures at the end. So we're going to start with the questions now. We have about 10 minutes for the questions. So we've got roving mics, and then most of the questions are directed to specific speakers. So when I ask the question, we'll just take it to the speaker. There is the first question, and this is Savitri, who says, I'm not sure who to address this question to, but GEMS is limited to government employees only for membership. Has any thought been given to opening GEMS up to other potential members? What are the restrictions against this? So can I ask maybe Dr. Stan to respond to that?
No, it's something we come across quite a lot, that there is question. So at the moment, the only people who are eligible to join GEMS, as was stated, is government employees. And also not all the government employees, only those that are employed in terms of the Public Service Act. Those who are in other state entities actually are still with other medical aids. The only way, so at the moment, the Medical Schemes Act is structured such that you have those who can join what you call restricted scheme, that is employee related. So we are a restricted scheme. And then we have open schemes where anybody can join. So one of the things that would have to happen for that to realize, and we know there's quite a lot of people who would love to join GEMS. We appreciate that's also an expression of confidence, is that legislation would have to change to allow, so we can either become an open scheme, which was not the intention of the mandate. The mandate of GEMS is to take care of state employees. So for now, it is not something that is realizable within the current legislation. However, we don't know what the future holds as we move. You know, we're going to go into a transition towards NHI and universal healthcare.
Yeah, wonderful. Thank you, Dr. Stan. Here's another question. And this one says, it's amazing I'm hearing about these initiatives by GEMS, and it's great to see that the patient is at the center of this. You've mentioned engaging with patients and HCPs. There is a stakeholder that is missing here, which is pharma. How does GEMS plan to engage with pharma, which provides the drugs to patients? Dr. Kola, can you maybe take this one, please? How do you plan on engaging with pharma?
Well, thanks for the question. We do actually engage with pharma quite a lot. We will continue to engage. I did mention earlier that we have an open door policy when it comes to stakeholder engagements. We do regard pharma as one of our key stakeholders. We actually have engaged in terms of medicine pricing, what we can do to have affordable treatment, especially in certain areas like treatment of rare diseases, which can be really expensive. So we continue to have engagement with pharma, and those, I guess, pharma companies that have not engaged GEMS, the door is open and we're happy to engage further.
All right, thank you. There's a question for you, Mapato, from Brian, who's asking, does the Competition Commission agree that third-party administrators should not have managed care organization licenses?
Thank you for the question. And I think it's a point that I missed in my presentation, that these corporate structures and corporate relationships exacerbate information asymmetry. I cannot say that the Commission discourages or cannot allow the licensing, but it's something that we raised in the HMI, that the CMS needs to improve on the accountability provisions, so that these corporate structures are able to account for the services that are being provided to members. Members sometimes don't know the difference between a scheme, the administrator, and even the managed care organization. When I have a problem and I call the call center and they say that this aspect is managed by our managed care provider, or this aspect it's managed by the administrator, it's very difficult to have accountability. But it's something that the HMI said is the CMS that need to look at this accountability and governance issues. Thank you.
Yeah, while you still have the mic, because there's another question, just the last one for you. This is Rayona, who says, I really appreciate your insights. There are multiple stakeholders across private sector with the capabilities to strengthen the healthcare system in multiple ways on HTA. Outcomes monitoring, etc. The greatest challenge, though, is the broader health system. It's not willing to accept the tools and have significant barriers preventing these from being adopted rapidly. So we need to allow for efficiencies and speed in our system. So someone asking for your view on that.
My view is that there should be some policy that guides HTA. We cannot have a situation where we have piecemeal interventions on HTA. Each scheme comes up with its own intervention, or any other stakeholder comes up with their own intervention. I believe there must be, at the macro level, some processes that manages HTA, so that there are no barriers, that there is transparency in the process. I think that's how I'll respond to that. Thank you.
Thank you. Here's a question for Barry Charles. The greatest challenge I've seen in trying to introduce alternative reimbursement models is that the MCOs managing the schemes are hesitant to engage in the discussions, to bring new ideas, to make the proposals stronger, and appear to lack the authority to commit to anything. So great ideas die before they can even take form. So how can we ensure that key decision makers are included in these discussions?
Question. One of the points I put up at the very end was one of the things, the characteristics that are required to see these things into market is persistence. It is difficult, and it takes a lot of effort and persistence and perseverance to see them through, make sure that everybody's at the table. We have seen some progress there. If you asked me this question 15 years ago, I would have said, yes, absolutely. We really, haven't really made any progress. But over the last 5 to 10 years, we've seen good models come to market. We've seen progressive schemes be willing to do pilots, like we heard about earlier, try new models. So I think we're making progress there. I'm encouraged.
All right, thank you. Dr. Sten, another question for you. What mechanisms are there to hold the treating providers accountable for utilizing technology, or even pharmaceuticals that are experimental, that lack scientific evidence and not covered by the scheme?
So, yeah, that's a very, so the question is, are we able to hold the health professionals accountable? And I think this is the conundrum for us. The only way it's not to pay for experimental treatment. So as a health provider, as a health funder, so strictly going about the business of a medical scheme, we restrict ourselves to funding. However, we have to make sure that funding is clinically appropriate. So we end up not paying for those things, but it is unfortunate. What is unfortunate is that the patients, the members, end up having to pay for those things that are excluded because they are experimental treatment. And that is, but we don't end by just not refusing to pay. In the engagements with the healthcare providers, we indicate to them that this is experimental treatment that should not be paid for. I think we would, if it is repetitive behavior, which would be deemed inappropriate, then we would approach the Health Professional Council and complain about it. Sometimes doctors do that when they genuinely think that it is the last option that they can use to get better outcomes. So the short answer is, the only thing, if it's repeated behavior, we can only complain to the Health Professionals Council.
All right, thank you. Just last question for you, Barry. Those were beautiful insights from the presentation. Following through the presentation by you, Barry, on the out-of-pocket payments, and agreeing that the low out-of-pocket could be that people do not even have access because they can't afford. For instance, in Zambia, a similar study on utilizations was done in 2015. Only 3.6% had insurance. 96% of those who accessed healthcare paid out of pocket, with 38.3% avoiding to access P because they could not afford. Now, with NHI being implemented, this has now changed, especially that a provision has been made for the elderly and vulnerable households accessing on an exempt basis. So the question is, in the absence of core payments, what are some of the mechanisms that can be used to curb the abuse in utilizations?
Wow, it's lots of complicated layers to get through there. The balancing act is funding and access. You know, the healthcare services, while they might be free at the point of use, whether they're delivered by NHI or the public service, cost money to provide. And when that money runs out, care is unavoidably rationed, either by stockouts or long queues or unavailability of services in different places. And so it's important that we are able to recruit enough money to pay for the level of access and care that we want in the health system, whether that's in the public or the private sector. So that whether it's a tax or an earmark tax or general tax or medical scheme contribution, that needs to be at the right level. That said, within that amount of funding that's made available, we need to ensure that the care is delivered in the most efficient way possible. And a lot of that is what we've been talking about today. It's a multifaceted problem that needs to be solved. Reimbursement models need to align interests between the stakeholders. Members need to be educated on the most efficient way to access care along those pathways that should be in plain language that they can understand, so that there's no uncertainty, etc. And the system needs to be honest about what it can and can't provide. And a lot of the misunderstanding around co-payments and what people are entitled to come from that miscommunication and misunderstanding. So there's a lot of work to do in those areas. But the brass tacks of it at the end come down to what budget's available and what access can be provided in as efficient a way as possible.
All right, thank you. Dr. Kola, someone is asking here, reference is being made to the HMI and the imbalance of market power. I would like to know what are GEM's views regarding corporates, like for instance, hospital groups wanting to corporatize specialist fields like radiology and pathology, increasing the market imbalance even more.
Yeah. Must be very careful how I answer this question. So firstly, I would like to say that, I mean, we refer to the health market inquiry quite often at GEMS. And when I say refer to it, is we go back to it and we look at the findings and we look at the recommendations with the intention of really doing what we can to try and I guess improve the market dynamics, improve the monopoly and the market share problems that are there. And we can only really do what we can in that respect. Whenever we contract with healthcare service providers, we always keep this in mind in terms of what the findings were and what we can do from our side to try and address those. I think that's I'm going to leave it at that for now.
Yeah. All right. Thank you, Doctor.
Thank you.
Thank you. There are many other questions that have come through, and what we're going to do is, because some of them we haven't had time to answer, they're going to be looked at and they will be sent to you after the symposium. And on that note, please help me welcome back on stage Dr. Sten, who will tell us where to from here in his closing remarks.
Thanks a lot, Clement. So, in Christian gatherings, usually at the end, they will ask the pastor to close in prayer. And what I have often realized in my church is that if there is a other visiting pastors, the one who's done the program will then say, out of respect for my mentor, Pastor Manyatela, can you be the one who's closing? Unfortunately, I don't have that option. I have to be the one. Otherwise, I was going to give that to you, Prof. Chetty, to come and close. So the question is simply where to from now? So if I use the same analogy of the closing prayer, what they usually do when they close, they then will quote in the closing prayer on the script that was read. So I've got so many scriptures that were read today. I'm talking about, all the speakers that have spoken today. So I'm not going to take excerpts out of that, but there's quite a lot that came out of our various speakers. And the main thing is, it is clear to us, putting the person, not the patient, because by the time we put them as a patient, they are already sick. So putting the person at the center of healthcare, it's very, very important. And that's what we must strive for. But for us to achieve what I was asking myself, if this is utopia, what you spoke about today, is it utopia? Is it something that is very perfect that we want to achieve in the future? And then I asked myself, I said, okay, we're talking about this patient centricity as something that we are saying we are doing some aspects of it at GEMS. But I think, and Basil said, how do you define it at GEMS? It really struck a note with me, because we used academic type of definitions and all of that to say this is what patient centricity should be like that. I even asked myself, and I hope I don't get into trouble with world leaders who do policy. I was asking myself if patient-centric care is like the Declaration of Alma Mater of 1978, which said health for all by the year 2000. Have that declaration been achieved? I'm not so sure. I don't know. We're talking about now universal healthcare coverage in the future. So it is clear that this patient-centric approach is something that all of us agree that it has to happen. There are some aspects of it that have been practiced. I think it's a matter of concentrating on certain things. So our involvement and our engagement with the healthcare providers to say, this is how we want what we are called health citizens to be treated. The health citizens are no more wanting to be just recipients. They are questioning and saying, well, I understand this is what I have. What are you proposing? Are you going to give me the same thing that I read about in the, what you call, which there's a call upon the doctors in the healthcare to move away from being paternalistic in their approach, the expert who knows it all, but involve the patients. There's a call for patients, families to be part of all of this. There's a call for all other healthcare stakeholders. Now it's not only the doctor and the patient, there's also the healthcare funders. There's also policymakers. There's so many people, the actuaries are involved in healthcare. All of us have got to have some form of picture of what we talk about when you say patient centricity. How are we going to get to this utopia? I think the most important thing is for us to be aware that it needs to be done. There are certain things we call in it at GEMS, we call your business as usual, the things that you know you need to do. When there's a call that says authorization, you have to do authorization. And those are the things that we know. But while we do that, we need to come up with a way of saying, how do we treat our members, our patients, persons, in a manner that it's a holistic approach. We must look at the gestalt, which is basically the holistic, the total picture, for us to be able to reach this patient-centered healthcare approach. And all these things that were mentioned by the various speakers that we say we are doing, there's a need for us to move away from looking at them in a theoretical manner, but to come up with specific programs that will make us to get closer to this. So we encourage everybody, including ourselves at GEMS. We have mentioned the things we are doing and will continue to on this road. It's a journey. It's not an event. And I want to thank everybody who participated in this webinar, both virtually and those who are here, all our speaker, Program Director Clement. Thank you very much to everybody for making this symposium. But most importantly, the team that was behind it all. Dr. P, thank you very much. Zoe and the teams, thank you very much for yet another successful 2022 symposium. Thank you.
Thank you, Dr. Sten. So at FIN, when you ask someone to come and thank their guests, normally the pastor will say, not even the pastor, the family representative will say, thank you guys for coming. Which basically means let's go home and have something to eat. And Dr. Sten was supposed to tell you that we're gonna have something. So for those of you who are here with us today, we'll be having a networking cocktail session. So would like you to stay and engage with us. But thank you very much for participating virtually and for all of you that are here as well. Thank you. The time was one day.
Some kind of love is taking all my time. I can't shake it off and it weighs on my mind. And now it's heavy on my. Now I see your face and everybody else and even if I replace you, I'll never feel as high. Oh, high. Never gonna get it, never gonna forget you, never gonna get it, never gonna forget you, never gonna get it, second chances, it's my only love. Whatever happens, I'll try to make sure that